Yes, sir.
Make Dr. Balabhaskar and C.R. Chandrasekhar, they are the this thing for the
Yes, sir.
moderate.
Already did, sir.
C.R. Chandrasekhar also did?
Yes.
Yes. Okay, right. Good.
I think we can start. Yeah. Good evening to all. We are starting the 7th webinar of ISA Kerala State chapter. I Dr. Venkateri, ISA National, for the introduction. Over to Giri, please.
Good evening, President Dr. Nazar, Secretary Dr. Binil, our faculty Dr. S. Ramesh and Dr. Sunil, our chairpersons Dr. Balabhaskar and Dr. Chandrasekhar, other delegates, we have Saikat Sengupta from Kolkata is there. I saw him entering, and many others. Anand Bangera is there from Mangalore, and many friends. Good evening to you all. This is the 7th webinar we are making from ISA Kerala. Our motto is there, get good speakers and give the good topics for all, which is interesting for both practicing anesthesiologists and for the postgraduates. With this, today we have two eminent faculties, Dr. S. Ramesh, who does not require any introduction to anybody. And he has selected a very good topic that near misses in pediatric anesthesia. With this, we have other speaker, Dr. Sunil PR, who is the professor of cardiac anesthesia at Chitra Tirunad, who is talking about the cyanotic heart diseases for non-cardiac surgery in children. So with this topics which are interesting for PGs to the senior most, will be useful for everybody, we think. One thing which I want to tell you all at this time is Dr. Ramesh talk is available only live, will not be available also. So be very attentive. Don't think that you will get this talk afterwards in the YouTube. That will not be in YouTube. With this, I request our president for further proceedings. Thank you all. Welcome you all.
Good evening, respected seniors and respected officials. Welcome to the 7th webinar of ISA Kerala State Chapter. Today, for this meeting, we have two eminent faculties, Dr. S. Ramesh, who is head of the Department of Pediatric Anesthesia, Kanji Kamakoli Trust Hospital, Chennai. He always speaks from his vast experience and is the most interesting pediatric anesthetic topic. He always talks based on his experience, and always all his talks will be full of the clinical evaluation and clinical experiences. We are really proud to have Dr. S. Ramesh with us. Sir, I'm really honored to welcome you to the state of Kerala and to this webinar on behalf of ISA Kerala State Chapter. Welcome, sir.
Thank you, sir.
And the second topic, which as Dr. Giri said, it's an interesting topic for the postgraduate, but I feel it is also interesting for the clinicians. Because Sunil is, as we discuss, is going to talk more on the practical aspects of this topic, a cardiac pediatric patient for a non-cardiac surgery. Dr. Sunil is part of and parcel of the Kerala State Chapter. Sir, I am welcoming you to this meeting. Dr. Sunil, welcome.
Thank you, sir.
And this session will be chaired by two eminent persons, Dr. Balabhaskar, who was always with us in all our webinar, making it lively and active. He is the chairman of ISA Academic Committee, National ISA. Sir, I welcome you to this meeting.
Thank you.
Dr. Chandrasekhar is heading the Department of Anesthesia at Sagar Chandrama Hospital, Bangalore. A person is renowned for his pediatric anesthesia interest. He is also moderating the session. Sir, I welcome you to this meeting. Dr. Chandrasekhar CR. We have the official, we are expecting Dr. Muralidhar Joshi, Honorable President, ISA National, and Dr. Naveen Malhotra, Honorable Secretary, ISN National. I hope they'll be joining us, and I extending them a warm welcome. I welcome Dr. Venkatagiri, President-elect ISN National, who is always deeply involved in all other organizations, in all other webinars, and helping us to keep the quality in high standard. Dr. Giri, welcome to this meeting. As you are part of this, but as customs demands, I am welcoming you. I am welcoming the President, the Secretary of our state chapter, Dr. Bidil Isaac, who is the man behind all these wonderful organizations of the webinar.
Thank you, sir.
Bidil, welcome you.
Thank you, sir.
I welcome all the state and national office bearers, past presidents, and the respected teachers and all members of the anesthesia family to this meeting. And now I'm handing over to Dr. Balvaskar for the proceedings of the academic meeting. Over to Dr. Balvaskar and Dr. Chandrasekhar Sia. Once again, I welcome you all and thank you, JIC.
So good evening to Dr. Venkatagiri, the President-elect of ISN National. Then the esteemed speakers of the day, Dr. Ramesh. Of course, I expect the numbers to go up by about 200 to 300 when he starts speaking.
That is in the conference, sir. That is the conference.
Here also, no, here also they're online. Okay, then Dr. Nazar sir, the President, Dr. Bidil Isaac Matthew. Then the speaker, Dr. Sunil. He is a very senior and experienced professor from Chitra Tirunal. And this is a very important topic for the PGs also to notice, in the sense that, again, exams are coming up for PGs across India. I definitely think and know that they will get a lot of take-home points so that they face examinations very boldly. Dr. Chandrasekhar is online. Dr. Giri, I was not able to get him online. So if he is there, he is a well-known pediatric anesthesiologist from Bangalore. He will also be partly, totally involved in the moderating this session. So I welcome both the speakers and wish the program all the success. Dr. Sunil will start now.
Yes, sir.
Yeah, please. Welcome. Please start the proceedings. Thank you. Good evening, Dr. Vishwanath. You are here. Thank you. Please start. Thank you.
Good evening, everybody. The topic for today is anesthetic management of cyanotic congenital heart disease for non-cardiac surgery. This is an era in which there are guidelines to cover the most mundane of situations, but there are no guidelines to cover the area of congenital heart diseases as such for non-cardiac surgery. The American College of Cardiology recommends appropriate consultation with cardiologists and anesthesiologists prior to non-cardiac surgery. But there is no evidence base, no large case series to manage the variety of cases found under the heading of congenital heart disease, leave alone the variety of diseases under congenital heart disease. Now, the four complications of congenital heart disease are cyanosis, cardiac failure, pulmonary hypertension, and arrhythmia, of which I will be focusing exclusively on cyanotic congenital heart disease. And once again, the children, a slight deviation from the topic, children receiving maximum attention should be shunt-dependent single ventricle lesions, single ventricle patients with AV, atrioventricular valve regurgitation. So these two are part of today's topic, but pulmonary hypertension with systemic or suprasystemic pulmonary arterial pressure and severe AS, they are not being covered today, but these are very serious conditions that should be taken with a lot of seriousness and managed appropriately. But my brief is the first two conditions. So cyanotic congenital heart diseases, the factor common to all of them is a limitation in pulmonary blood flow. There is not enough pulmonary blood flow, and because of that, and the reason for that is that there is a right to left shunt. And these patients, before they present for non-cardiac surgery, they are likely to have undergone a lot of interventions soon after birth. So the patient presenting to you may have had either corrective surgery, in which case it is good, or may only have undergone a palliative surgery, in which case a patient needs a lot of care. Now, this is a model for a congenital heart disease. I have taken tetralogy of Fallot. You can see that there is this displacement of ventricular septum leading to the VSD, and there is the overriding aorta, hypertrophied RV, and there is restriction to pulmonary blood flow. So this is the tetralogy of Fallot with all the 4 features. And this patient, you will notice, has 2 good ventricles. He has the right ventricle here and the left ventricle here. Anatomically, they are well formed. So this patient will undergo a corrective surgery in which he will have both ventricles available to him after surgery also. So when a correction is done, the VSD will be closed. The outflow for the pulmonary artery will be opened up, and the RV hypertrophy will in time regress, but some RV dysfunction may persist, and residual lesions could be there after corrective surgery. Now, other conditions in which a 2 ventricle repair, that the patient has 2 good ventricles, and the repair will also leave him with a desirable state of having 2 ventricles. This tetralogy with pulmonary stenosis, tetralogy with pulmonary atresia, transposition of great arteries, TAPVC, truncus arteriosus. And in this, these 3 conditions, transposition, TAPVC, truncus, they get operated very soon after birth. They are likely to present with corrected diseases at the time of surgery, whereas the other 2, they can present for emergency surgery or even elective surgery. Now, there are conditions in which the deformity is such that there is only 1 good ventricle. So there is anatomically only 1 ventricle available. Because of that, there is mixing of systemic and pulmonary venous blood either at the atrial or ventricular level. And this mixed blood is circulated out simultaneously to both systemic and pulmonary bloods. Now, let's take the example of what we call the hypoplastic left heart syndrome. In this case, you will notice that there is a good RA and a good RV, but the mitral valve is atretic, small. There is LA, but the LB is quite small. And the patient has only 1 good ventricle, which is the right ventricle. So in this, even this cannot be corrected to surgically repaired to such a stage that the patient will end with having 2 good ventricles. There is only 1 ventricle to begin with. After surgery also, he will have only 1 ventricle. And that 1 ventricle will be dedicated to the systemic circulation. If you see here, there is RA, good tricuspid valve, good RV, and that RV outputs to the aorta. And whereas the left atrium is draining to the RV, and it is again RA and draining to the RV and again into the aorta. So there is a common output for both the chambers into the aorta, and pulmonary blood flow is through a PDA. So a full correction is not possible in these type of conditions. The patient undergoes palliative surgeries. So conditions with this kind of structurally single ventricular hypoplastic left heart syndrome, tricuspid atresia, doublet left ventricle, and so on. So this is called the single ventricle palliative pathway, where there is a 3-step surgery. Immediately or soon after birth, the patient will undergo a modified BT shunt. And within 6 months, will undergo a surgery called a bidirectional Glenn shunt, and a completion of the palliation by 4 years of age, and the procedure is called Fontan surgery. Now, I'll show you what's the BT shunt. BT shunt is familiar to all. That there is this is called a modified BT shunt, where a connection is made between the subclavian artery to the pulmonary artery through a tube. So the idea is to provide pulmonary blood flow. Cyanosis is because there is reduced pulmonary blood flow, BT shunt provides pulmonary blood flow from the subclavian artery through a tube and saturation is maintained. But this is first stage of palliation. BT shunt is taken down by about 6 months of age at the latest. And what is done is the superior vena cava is then connected to the pulmonary artery directly. And this is called a Glenn shunt. Now the blood flow to the pulmonary artery is by superior vena cava. The inferior vena cava continues to drain into the RA and RV. Remember, this patient has only one ventricle. So LA should drain into RA and then into RV. And this output goes to the systemic circulation. So when there is only one ventricle, whether it is right ventricle or left ventricle, it is dedicated to the systemic circulation. And pulmonary blood flow is provided by alternate means, as we have seen in this condition, through a surgery called Glenn shunt, where SVC is connected to the pulmonary artery directly. Now the important point is, if you put any IV line in the internal jugular vein, it is straight away goes to the pulmonary artery. There is no complicated circuit to reach the pulmonary artery in this patient. Any IJV catheter ends up in the pointing to the pulmonary artery. So any pressure from the IJV is PA pressure. And likewise, since SVC is providing pulmonary blood flow, any head down position is poorly tolerated, because if it is head down, there is venous congestion in the head and the patient becomes irritable. And likewise, the pulmonary vascular resistance, the lungs are here, the pulmonary vascular resistance has to be low, otherwise this flow will not occur. Now the third stage of palliation is called the Fontan. Earlier we saw that the SVC was connected to the PA. Now the IVC is also connected to the PA. Now all the venous blood is going to the pulmonary artery. So this is the third stage of palliation. The palliation is completed. So first stage was BT shunt, where we provided pulmonary blood flow from the subclavian artery. There the best saturation will only be 85%, somewhere between 75 to 80% at best. Higher is bad, lower is bad. We'll come to that later. And when the Glenn shunt was done, the saturation does not change, 75 to 85%. With the completion of Fontan, we can expect a near normal saturation, but it still remains that the patient has only one ventricle. And this is that one ventricle, and that one ventricle will supply the systemic circulation through the aorta. Pulmonary artery is completely disconnected from the heart, and blood flows from the SVC and IVC. Now we come to the Eisenmenger syndrome. Eisenmenger syndrome is a situation where there was a left to right shunt, like most commonly atrioventricular regurgitation. These are the cases which undergo permanent changes in the pulmonary vasculature and develop pulmonary hypertension, irreversible pulmonary hypertension. And because of that, what was a left to right shunt becomes a permanent right to left shunt. And in these conditions, surgery should be avoided as far as possible, because there is very high perioperative mortality. Without, if these patients are do not develop any other diseases, they can have survival into the 4th decade or even the 5th decade. But surgery increases their mortality. So insofar as possible, surgery should be avoided in this patient. And predictors for poor outcome is poor functional class in the day-to-day normal life, arrhythmias and syncope. Now, coming to the consequences of cyanosis, usually in this patient, whenever the saturation is low, and you can expect only saturation of less than 85%, even with a palliative surgery, what happens is secondary erythrocytosis due to erythropoietin secretion due to chronic hypoxemia. There is an increase in hematocrit, increase in RBC volume, and there is decrease in platelet count due to decreased platelet life. And there are low levels of factor V and von Willebrand's factor. And on lab tests, they are known to have high INR and APTT. But despite all this, the elective surgeries can be safely done, but I would advise caution before stage 2 palliation in single ventricle. That is, in those patients with single ventricle pathology, surgery is best done after the Glenn shunt, not before the BT shunt, not after the BT shunt, but after the Glenn shunt when the patient's saturation has improved. And caution is required in Eisenmenger syndrome. And during pre-op evaluation, the red flags are and cyanosis, and I have not written it here. Another red flag should be a high hematocrit. I have already mentioned the problems with the high hematocrit. There are twin consequences. One is that this chronic hypoxemia causes decrease in clotting factors. Does not mean that they will bleed more. Actually, they are as susceptible to thrombosis on account of their high hematocrit. And because of the high hematocrit, they have peripheral, because of their cyanosis, they have peripheral arterial dilatation also. So on account of that, they are likely to bleed also. So this is a twin risk. They bleed more and they have risk of spontaneous thrombosis also. And another red flag I've already mentioned is poor functional status. Pulmonary hypertension is a red flag in congenital heart disease, not seen usually in cyanotic congenital heart disease. They are usually a feature of left to right shunts, which we are not discussing today. Again, congestive heart failure is another red flag, but not found in cyanotic congenital heart disease, because remember, we are dealing with a situation where there is less pulmonary blood flow. And the nature of the surgery, if the patient requires Trendelenburg position, prone position, or one lung ventilation, the operative morbidity and mortality is higher. So during pre-op evaluation, assess functional class, especially for assess for recent respiratory tract infection. And these are patients who require their PVR to be manipulated. It does not help if the patient has bronchospasm. And check for the room air saturation. And that is the saturation, that's the best saturation you're likely to get during the surgery, even with positive pressure ventilation. And blood pressure readings should be recorded in the OPD itself to know what is the normal blood pressure. Review the lab results and the hemoglobin in particular. Hemoglobin more than 20 grams per deciliter is a red flag. Platelet count, INR, APTT, all should be measured. And liver function is often altered in patients after Glenn shunt. The reasons we will not go into now, but that is one area to be evaluated carefully. And review the medications, beta blocker, diuretics, angiotensin converting enzyme inhibitor, aspirin, anticoagulants. So the anticoagulants should be discontinued sufficiently prior to surgery. Aspirin, if is there, can be continued. And the debate continues over whether to continue with AC inhibitors or not. Mostly the preference is to discontinue them before surgery. So the chest X-ray is an important tool, and even more is echo. The patient is likely to have multiple echo reports and CT scans. Read them all. And important question, what primary? Another important question, is this a single ventricle physiology? And review what procedures the patient has undergone for congenital heart disease. And further, in echo, the points of interest is degree of RV outflow obstruction and the source of pulmonary blood flow. What is the source of pulmonary blood flow? How does the pulmonary arteries receive blood? Is there any antegrade? That is there blood flow from the RV to PA? Is there only a mild pulmonary stenosis or severe pulmonary stenosis? Is the source of blood flow from the BT shunt or from a PDA or from any other aortopulmonary collateral? If there are any major aortopulmonary collaterals, which essentially performs the same function of PDA, but not in a good way though. And see what is the stage of palliation if the patient has undergone any of the palliative surgeries. And if the patient has had a completely corrective surgery, also check for if the any residual lesions, mostly residual VSTs, if there is any residual right ventricular obstruction, is there any right ventricular signs of right ventricular failure, any pulmonary regurgitation? All these should be checked. And prior cardiology consultation is a must, and the crucial question to be answered is the patient condition optimal for surgery? A mere fitness for surgery is not enough. Regarding fasting and pre-medication, preoperative fasting should be minimum, especially if the patient has a high hematocrit. And the patient should be continued on oral, and if when oral is discontinued, intravenous hydration should be started in cyanotics because their hematocrit is high. And when it comes to pre-medication, hypocapnia and hypercarbia are deleterious in patients who need to have a low PVR, as in patients with Glenn shunt or Fontan. But usually they retain normal ventilatory response to hypercarbia. So mild pre-medication with a mild sedative pre-medication is not contraindicated. That you have to assess the risk-benefit ratio in those situations. Now, routine monitors, ECG, end-tidal carbon dioxide. One word of caution about end-tidal carbon dioxide. When there is a right to left shunt, the ETCO2 is not reflective of the PaCO2. The gap tends to be much wider because remember there is decrease in pulmonary blood flow, and temperature should be monitored, which is, temperature is a factor. Hypothermia can increase PVR, pulmonary vascular resistance. And pulse oximeter, one word of caution, avoid it on the side on which the Blalock-Taussig shunt was performed, because on the side it was performed, blood is being shunted away from subclavian artery to the pulmonary artery. For similar reason, avoid arterial BP on the side of BT shunt. So if you place pulse oximeter and arterial BP on the same side of BT shunt, you're more likely to have falsely low values or no values at all. So regarding monitoring, remember what I said about Glenn and Fontan. Any line placed in the internal jugular vein is facing to the superior vena cava and facing the pulmonary artery. So IJV pressure is not CVP, it is straight away PA pressure. And any femoral vein placed in the Glenn shunt is the direct route to LA. So any lower limb venous line you place in a Glenn shunt goes through the IVC into the RA, where blood from the LA also comes, and they mix, go to the RV, and they go to the aorta. So be very careful to avoid air bubbles in IV. And the use of TE for monitoring is definitely useful if it is available. Now coming to infective endocarditis prophylaxis, this has undergone a major revisions more than a decade back, and it has not changed from there. And infective endocarditis is advised only for select situations, because it is not useful when it is used in a widespread manner, but the risk is more than benefit. The best benefit, the best way to prevent infective endocarditis is to maintain good oral health and hygiene more than administering infective endocarditis. But infective endocarditis prophylaxis is advised in those situations where if the patient develops an infective endocarditis, the patient will have a life-threatening risk. So any patient who has undergone a prosthetic cardiac valve, patients with previous infective endocarditis, unrepaired cyanotic congenital heart disease, unrepaired cyanotic congenital heart disease, completely repaired congenital heart disease with prosthetic material. So that's one thing you should look for in the preoperative echo. And repaired congenital heart disease with residual defects, the site or anywhere else. So if for these patients, there is prohibitive, the risk is prohibitive if they do develop infective endocarditis. So antibiotic prophylaxis is advised only in these select situations. If the oral drug is amoxicillin, if oral is not possible, it is ampicillin or cefazolin. If those allergic to penicillins, cefalexin, clindamycin, or azithromycin or clarithromycin. So I'll not go into the detailed doses. I suppose this presentation will be available online. So regarding anesthetic management, there is no single approach is possible because the disease is not a uniform disease. There are multiple defects and affects and the correction is in different ways. So, there are few aims that we can, we can aim for a few things. One will be preventing arterial desaturation. More of that in a minute. Maintain balance between pulmonary blood flow and systemic blood flow by balancing pulmonary vascular resistance, and anesthetists in the unique position to manipulate pulmonary vascular resistance, and optimizing the hematocrit. Meticulous care to avoid air. The elective use of tranexamic acid is advocated because they have this coagulation dysfunction. Avoid prolonged fasting. Ablate sympathetic stress. Sympathetic stress increases both SVR as well as PVR. Prevent and treat acidosis by maintaining a good circulatory state. Maintain age-appropriate heart rate, sinus rhythm. Maintain preload, maintain contractility, and maintain the SVR that I mentioned earlier. So be generous with IV hydration in patients with cyanotic congenital heart disease. And regarding cardiac contractility, and there's a word of caution: do not increase contractility in cases where the patient has a history of cyanotic spell. The patient develops cyanosis on stress. That means there is a dynamic spasm of the RV outflow. So in these patients, increased contractility by use of inotropes is to be avoided. So what happens in a patient with worsening cyanosis under anesthetic? Of course, the first reflects the increase in oxygen to 100%. In each chest position, a maneuver to increase preload and increase the SVR, systemic vascular resistance. And if it is a cyanotic spell, or the reason for this worsening cyanosis is sympathetic stress, fentanyl bolus or morphine bolus is advocated. What I would particularly advise is ketamine 1 milligram per kg, because at this time when the cyanosis is worsening, the SVR needs to be propped up so that more of the left to right shunt can occur. And besides, ketamine there will be hypotension, and ketamine will not cause hypotension, unlike fentanyl. And the intravascular volume has to be expanded with crystalloid boluses, 5 to 10 ml per kg. Another drug which is useful at this time is phenylephrine, 5 to 10 microgram per kg IV as boluses. Now, if it is a cyanotic spell, the patient will benefit from a beta blocker, esmolol or propranolol. And use of sodium bicarbonate is a two-edged sword here, because on the one hand, administering sodium bicarbonate will cause volume expansion and will help with the overall goal of increasing the preload. But on the other hand, sodium bicarbonate is a buffer only if the lungs are able to excrete carbon dioxide. In this particular situation, the lung is good and the lung can excrete carbon dioxide, but there is not enough pulmonary blood flow reaching from the right ventricle. So this is a two-edged sword, has to be used cautiously. And if the patient is not intubated, the cyanosis is worsening, intubation should be quick with ketamine rocuronium. If can be given intramuscularly if there is no IV available. Now, to select situations for following a BT shunt, again, I would advise any very meticulous care to avoid air. Any air bubble trapped in that BT shunt will absolutely cut off blood flow from the subclavian to the pulmonary artery. The expected saturation is 75 to at best 85%. And that is to be attained by a balance of SVR and PVR. I'm coming to that in a moment. And systemic hypotension should be avoided because it decreases pulmonary blood flow. Sympathetic stress will increase SVR. So interventions, conditions that can increase PVR and interventions that can avoid them. Conditions that can cause increased pulmonary vascular resistance is hypoxia. The intervention which will decrease the PVR is increasing the FiO2. Increasing the FiO2 itself is enough to decrease the PVR. There is no need for that increased FiO2 to be reflected as increased saturation. Increase in alveolar oxygen tension itself is enough to decrease the PVR. Respiratory acidosis, hypercarbia, these increase the PVR. These can be treated with hyperventilation. And sympathetic stimulation should be proactively avoided with adequate opioid or ketamine boluses. Hypothermia should be prevented. Once hypothermia sets in with poor circulation, it is difficult to correct. So it should be prevented. So it's a BT shunt is a mildly restrictive shunt which imposes volume load on the left ventricle. So in a BT shunt, if you lower the PVR excessively, in a BT shunt, flow depends on balance between PVR and SVR. If you lower PVR, more blood flows to the pulmonary artery and saturation goes up beyond 85. So in a patient, BT shunt patient who was saturating 80 or 85, if he develops 100% saturation, that's not a good thing. That means blood is stolen from the systemic circulation to the pulmonary artery. So do not decrease the PVR so that the saturation goes up. Keep the FiO2 low, allow the PCO2 to be a little higher. Anesthetist is in the unique position to manipulate PVR as required. And this can cause coronary steal and systemic hypoperfusion. So high saturation is a red flag in a BT shunt. 80 to 85% is all that is required. So this I've covered. And again, do not lower the SVR too much. If you lower the SVR with too much volatile anesthetic, the saturation will fall and the shunt can get blocked. So it's a fine act between balancing SVR and PVR. That's why I said, do not take these cases for elective surgery. Only emergency surgeries should be done. They are better, better tolerate non-cardiac surgery after Glenn shunt. So in Glenn shunt, again, this is already covered, but I will repeat. What is important is that spontaneous ventilation is better than controlled ventilation. The reason being, when there is spontaneous ventilation, as opposed to positive pressure ventilation, the SVC will drain freely into the PA because in the intrathoracic pressure is not high because of IPPV. So spontaneous is great, better than controlled ventilation, but you may have to intubate for a abdominal surgery, but prevent high airway pressures because they decrease preload. Again, I've said Trendelenburg position is bad because head down will cause blood to pool in the SVC, the intracranial venous sinuses, and there will be no pulmonary blood flow. No pulmonary blood flow means poor saturation. So again, expected saturation is 75 to 85 range. It will not increase more than that. And this saturation you will obtain only if you keep the PVR low. No need to balance the PVR, SVR as in a BT shunt, just keep the PVR low. And avoid use of high PEEP. Again, I once again mentioned that the lower limb venous line are a direct pathway to LA. So air should be avoided at all costs. And because of the coagulation dysfunction, epidural spinal is not the method of choice. But I can provide the reference for those interested. People have given spinal anesthetics to these patients. The reason why I do not advocate is not just coagulation dysfunction. These lesions are also preload dependent lesions. And you are not able to manipulate the PVR after you administer an anesthetic like that. So this is not advocated. Regarding the conduct of anesthesia, sevoflurane induction is safe if done carefully, but it can cause arteriolar dilatation in patients who already have peripheral arteriolar dilatation because of their chronic hypoxemia. And sevoflurane can also decrease in SVR. We will not be able to fine tune that ratio between SVR and PVR, but sevoflurane induction is used and is safe if done carefully. Intravenous drugs, ketamine for induction is the usual choice for me. Etomidate has also been advised in literature. I have not used. And conduct of anesthesia should be a balanced anesthesia with the use of volatile for maintenance and opioid. Sevoflurane and fentanyl are my drugs of choice. And extubation should be assessed on case-by-case basis. It is best for these patients to undergo early extubation because single ventricle lesions, they function well when the patient is breathing spontaneously. And post-op pain, shivering, all place high cardiac demand on cardiac output, which these patients are not able to cope. They will not be able to provide this high cardiac output. And the risk is high in patients who require post-op ventilation. With that, I conclude. Thank you.
I think it's,
I have concluded.
yeah. Thank you, Dr. Sunil. I think we can go with the second topic and then take the questions at the end from the chat box. So I request Dr. Chandrasekhar to invite the next speaker. You can unmute yourself, Dr. Chandrasekhar. You can unmute yourself.
Yeah, can you hear?
Yeah.
Yes, sir.
I think Talaiva has come on screen. He doesn't he doesn't require any introduction, and the topic he has chosen is really fantastic because mishaps do occur in anesthesia, and one should have guts to say that these are the things which have happened. In the olden days, there were no records available, but now NABH and all have made it mandatory that reporting of critical incident reporting. So maybe in few years down the line, India will have its own record of misses and mishaps which are occurring in this thing. I welcome Dr. Ramesh to proceed with this charming talk.
Thank you, Chandrasekhar. Nice to see you here. Huh?
After
Chatting is
a long
good.
time.
Yeah, we keep talking to you. Don't worry.
Okay.
I'm just sharing the screen. Is the screen visible?
Yes, sir. We can see a good cup of coffee.
Yeah. That was given by my wife now, sir. That's one of the advantages of having a webinar at home, because she looks after you, gives you a good cup of coffee and all these things, and then makes you comfortable, sir. It's quite okay. So anybody wants to have, I think it's night time at 8 o'clock, want to have a cup of coffee, can go and come back, and then we can, it's about 8:10 right now, maybe in another 45 minutes, I'll finish this. So you can have some coffee and come back. So my topic is on near misses in pediatric anesthesia. Actually, before I talk, I must thank Dr. Venkatagiri. We are very close. I think we have been associated for probably about 20 years from for many of the meetings and things like that. And more than anything else, I must thank Dr. Venkatagiri, because I must tell, my daughter is watching my talk from Boston. So what she thinks that I don't know much of anesthesia, only Boston children, they know much. So at least she's given a chance for her to listen to my talk now. This is the first time she's listening to me. So I must thank Venkatagiri for giving this opportunity of giving this particular talk. And as you know that we are all not very good in all these webinars and conferences, you know what are the rest all these things. Whereas in webinars, I don't know who is watching and who is really talking, who is sleeping, or who just switched on the webinar and gone somewhere else. So it's very difficult really to judge what's really happening. So this is what, so I was listening to this ISA Kerala branch has given a good webinar, but how to conduct a webinar and how to be a participant, and the topic of webinar, it equates like this in this one. Dr. Udupa, host, I just want my video to be on, Dr. Udupa.
Yes, sir.
Okay. So this is actually, it's so that made me a little bit of confidence what else to be done with all the things. So that made me confident do exactly what to do. And one of the slides, they showed participants and delegates. He says you should not have, during that, have no coffee, fielding a call. You should not have a domestic distraction and things like that. So he said avoid eating and drinking. But how is it possible? And for Keralites at about 8:30, ask them not to drink now at 8:30. I think we should have some beer. If anybody wants to have a beer, you can have a beer and be. Is it? And especially for Chakra Rao, I have never seen in webinar without his beer glass in any of the webinars. So all these people, we cannot stop. Let them have the drinks and things like that. And the second, they told me mute your videos and mics. I think that's a very important, because if you don't mute, a lot of echoes and things like that. And it's always recommended. Many of them, they told we are not able to hear properly and things like that. So you recommend to use the earphones. So you all use your earphones when you're using a cell phone or laptop. Please use earphones so that you can hear properly. You can reduce your volume and things like that. For the speaker, you told that have correct display name in the profile and things like that. The only thing is, you told make sure you're well dressed, and in the red top, you said at least top portion. In the bay, you can put lungi or vesti or dhoti, whatever you want, but at least the top you dress properly. That's what he told. So we have to dress properly in the top. And he said you start with a nice joke. So I just thinking what to show, but I am to please the ladies as well as the men. So I have chosen a joke where we will be able to please both of them. So I think behind every successful man, there's a woman. I think ladies are very happy if you sell that with this. I think they are quite okay, because most of it, if you're okay with, it's okay. But next, if you need more success, increase the number of women. I think the men are very happy if you listen to that. I think that's a good saying, I think. Nothing is said that is not said before. So I have doing lectures for about 25 to 30 years, and most of the time who are listening to me must be knowing what I'm going to talk, because nothing, you cannot miss many. All 30 years, every time one miss. So only about 10 or 12 misses we'll have. I'll keep on talking about the same thing. So if you'll be listening somewhere the same particular case, but I can't help it, because I don't want to have more and more of near misses. But I may not have the photographs of the near misses, because we may not have all the time with the photograph to have that I will miss right now. For example, in football, as you see this is a football where he's kicking from the top, and then in the football they can do it because they have all the you can see this. The camera photograph is all the time at 40, about 1.5 hours. The cameras are all on continuously. So all near misses are taken. But I don't think in anesthesia we'll be able to have near misses taken at that time. But so all this, and moreover, in olden days, when I started my career, I don't think I had that camera. Those days, if you have a camera, only one photographer for the whole hospital will have, and only the pathologist department will have. We have to book it long before to bring the camera and things like that. When you are not able to intubate, we cannot call, come, I'm missing something, can you take a photograph? So I think that's not possible, but I think the cell phone and things made me, you see, more at that time, the cameras are very expensive, not only expensive, but also the films developing and all these things, as anesthetist about getting a salary of 1,500 rupees in 1982, I don't think I could have afforded that time. So after 35 years of working as an anesthesiologist, occasionally fool myself in believing I have seen it all. That I don't think I can tell you that I have seen it all. The truth is that no one ever sees every possible clinical scenario. Unique presentation can occur whether your first day of anesthesia residency or last day of a long eventful career. Even today, I may miss tomorrow. So we cannot really tell that I have done everything and then nothing can happen to me. So only by sharing experiences, you can, everyone can learn from them. You got to share. So for example, as you know that Kerala is, I always take the football because Keralites are, fond of football. As you know, the Kerala Blasters are really doing well. Of course, next to Chennai. So this is just want to show you how even experienced people can miss it. You should never be overconfident in this. So you thought that you have done everything, but you will be overcoming, gone, and then goal is there. I think you must be very careful, even if you're this is okay with that. So what happened is I did my Tanjavur Medical College. Then it will be then I went to Jibmar for non-PG junior residency. From there, luckily I got in Chandigarh MD. Then after Chandigarh MD, I came back to Chennai Apollo. I think I was the first second registrar of Chennai Apollo in 1983 when they started the Apollo. And after the Apollo, then I had a chance to go to Saudi Arabia. At that time, you also need some money. So I went to Saudi Arabia. Saudi Arabia, I was in maternity and children. I think that's where my pediatric anesthesia started for a long time ago in 1985. And from Saudi Arabia, I came back to Chennai and started Child's Trust because I want to continue with pediatric anesthesia. And I'm going to tell whatever I remember in every place so that it will be of some use to you. It will be more of stories, may not be very scientific in that, more and more of stories. I think that's okay. I think 8:30 to 9, I think we'll listen to a lot of stories. And Apollo in 1985, this is where happened in 1985. I was, interested in pediatric, even at that time, about 10 months old baby, they want to do a circumcision. It's about 9-kilo baby. And actually the surgeon is from Jibmar. He's from North India, and then Jibmar pediatric surgery. And, the Jibmar, the Chandigarh and All India Institute, they're all thinking that they're all brothers. So he asked me, where are you coming from? I said, I'm coming from Chandigarh. Okay. Then suddenly they will talk only in Hindi, Oh, kya karta hai, oh, acha hota hai, tomorrow, at the time I can't even understand English, Hindi properly, but somehow I said, okay, I've come there. Why don't you do tomorrow, 10 months old baby? We can do on circumcision. I told I'm registrar, but consultant only will do. No problem. You are okay. You are from Chandigarh. You will go, okay. I will tell the consultant. So this is okay. So that time I remember there is one called, I'm sure Balabhaskar will remember, there is one called syrup Velargon available. This is trimeprazine. Actually, that was very good. And so that is a very good pre-medication. So I wrote to syrup Velargon 4, 5 ml at about 5 o'clock, about 1.5 hours before we will be able to. So I gave Velargon, syrup Velargon, 1.5 teaspoon, and give it 5 o'clock. And then I put a line, then gave this one, held the mask. That time no LMA and all these things, held the mask, and then gave caudal, and everything was very good. So he was happy. Oh, acha karte hai, oh, acha karte hai. After some time, child is not waking up. You see, this is the first case I'm starting, and child is not waking up. And then it took about 7 o'clock we started. It finished at 7:30, and then up to 9:30, 10, is breathing slightly but not waking up. Again waking up. What is this? What to do? What it is to be done like that? So it took about 3 hours. Slowly started breathing and all these things. At that time I was sweating, and the situation at that time. There is two types. There is one is called syrup. One is a syrup, Velargon syrup. That's a plain syrup which has got 7.5 milligram per ml. There is another one, what is called Velargon Fort, which is 30 milligram per ml. So if you give 1 teaspoon of this, you are giving only 7.5. So 5 ml, 1 teaspoon of that will give 30 milligrams. So instead of syrup Velargon, which is plain, they are given Velargon Fort. So after that, I found out they were given a fort. It took 3 hours for them to wake it up. And so luckily, I could find what they've given. And then we found out. Otherwise, you would have thought that something's gone wrong with the caudal, because that time I'm just a beginner. So all these things happen that you must be very, very clear when you are writing that, the Velargon fort. I don't know. In India, many of the drugs, good drugs are all gone. Velargon is one of the beautiful pre-medication drugs used to write, but now Velargon is gone. That is trimeprazine taught right. It's one thing which happened in 1985. You must be very careful. Luckily, we found out what it was, and the child was all right. Okay, from there, I went to Saudi Arabia. In Saudi Arabia, people used to say, you must be very careful. If there's something is wrong with happen to the child or somebody, you have to pay 100,000 Saudi riyals. In 1988, there is no insurance. See, your salary itself, if you ask, are the 3 years together, you can't get 100,000 Saudi riyals. So how will you pay? So everybody will say, don't take any risk, be careful, don't take small babies and all these things. But it's a maternity children, so I have to check everything. I cannot refuse. So I said, okay. That particular child, what happened is there is two cases happen. One is actually the child is a newborn, which is a Down syndrome, and it is a Saudi child, and it's a Down syndrome with a duodenal atresia, which is about 2.8 kilo baby. See, even in 1988, I had a non-invasive blood pressure in Jeddah. It is actually one of the very beautiful hospitals. So I am lucky to be in a children's hospital. That's why my pediatric anesthesia also has developed like that. So I went there, and that particular child, I don't have the photograph of that particular child, but I'm just showing this simulated one which has happened at that time. So this is about 2.8 kilo baby. I'm doing I put a non-invasive blood pressure and everything was all right. Put some line, everything was okay. And then started and all, they were very happy. And the surgeon is actually a Palestinian. And he was very happy because they all like me, you know. So he said, okay, come, let us do duodenal atresia and all. Okay. I did everything and all these things. He was losing blood when they were operating. And during the blood, I brought the blood and then I was giving the blood. See, that time I'm a consultant at that time. So every consultant is independent. Nobody will cover you. So this is, I was just giving blood coming and all these things. And after some time, he started doing something. I found that NIBP was not measuring. There was pulse oximeter also, but there was no ETCO2 at that time. The pulse oximeter was not picking up very well. We don't have a very good pulse oximeter those time. And I couldn't feel the pulse much, and slowly it is coming down and BP is not recordable. Heart rate was about 140, 150. Then I told, sir, something is wrong. Then suddenly I pushed blood, and the BP was not picking up. Then I found the line which was there has come out because it's all been covered. The whole child was completely covered. The line came out, and then whatever blood I'm pushing is coming out and it is not going to the patient. So God, you can imagine. And that fellow is a Palestinian. He keeps on telling me, oh Ramesh, the patient, you are losing the child, you should have 100,000 Saudi riyals. Oh God, you can imagine, already a child is dying and I have 100,000 Saudi riyals. How is it can do like this? So somehow, then he said, I will do a cut down. So he immediately started a femoral cut down. In femoral cut down, another 10 ml of blood was lost and he was not able to do a femoral cut down. Oh God, something is happening. Then I said, what is happening like this? At that time, I am not very good in putting central lines and things like that, especially emergency, no ultrasound. So luckily, you could get some line in the saphenous, and then I put some pain, and then resuscitated. Everything was all right. And then he did anastomosis. The child was ventilated and child became okay. So the lesson I learned in that particular, which is almost we lost the child, is that after that, I made sure that we have got, this is what is called ether screen. Whenever there's a possibility, except in neurosurgery or something, you put a ether screen. This is, we call it ether screen because those days when you use ether, it is flammable. So if you use diathermy, it can prevent flammable. So it is called ether screen. So one thing, Praveen Udappa is giving some, okay.
No, sir, you can continue, sir. Sorry.
Continue. Okay. You given me some message. I thought something is wrong. Okay. So this one is, so you have to put in a, okay. So what you would, you put a screen like this so that we can see some IV line. And you can see the endotracheal tube connector here, because this I always make unless in neurosurgery. So from that time onwards, I make sure that I see the IV line and I see the tube so that both can be seen when you are doing it. I think that's a very, very important. Many of the pediatric surgeons tells me that, you know, Dr. Ramesh is afraid of the blood. That's why he is putting the screen. At that time, for everybody, I can't tell this Saudi story, but it is in my mind whenever I'm putting this particular screen. So I remember you must have something. If you don't have this screen, you can at least put the 2 IV drip, put a cloth so that you can see the upper end as much as possible, so that if anything, you can always do something. Especially when you put an LMA, your LMA slips, you can put tube. I think all the head end and something has to be visible to you and see the color. All these things are very, very important. This also happened in Saudi Arabia. This is actually what happened in Saudi in maternity and children's hospital. Is though it has not happened to me, it has happened to one of my colleague consultant. There are 2 operating rooms, and then one of the operating room, there's about 80-year-old child. 80-year-old child, they did a tonsillectomy, and there's a consultant and there was a fellow. And the consultant, actually, she's a Nigerian, British qualified Nigerian, and she did that. She's responsible. Their consultants are responsible, but the fellows are not responsible. So she was there for us all the time. At the end of it, she told the fellow, please extubate at the end of it, because I have got some work in the Ministry of Health. I'll go and come back. So she said, okay, no problem. So she came out of the operating room. Actually, there, I don't know where people have seen CMC Vellore, the patient is shifted from the two trolleys. The glass door will just keep lifting up, and just have to move one trolley to the other trolley, and they go there. So similarly, there is a glass window will be there. It comes automatically, the glass window went up, and the case sheet was given by the sister, and the consultant signed there, this patient can be transferred. Unless the consultant signs from the recovery room to the ward, they will not transfer the child from the recovery room to the ward. She signed it and went to the maternity, to the Ministry of Health. After that, this girl said extubated, and the recovery room. In the recovery room, child was little restless. At that time, there was little bit of only diazepam was available. She gave little diazepam. Child become little quiet, and after about half an hour, this is already signed. The sisters transferred the child to the ward. In the ward, child arrested. In the ward, child arrested. So luckily, the ENT surgeon was there. He didn't know. He thought something is wrong. So immediately you took the laryngoscope, and then he said he saw the endotracheal tube, and that inside the endotracheal tube, because there will be a problem. So immediately brought the endotracheal tube and showed everybody the endotracheal tube is left in the oral cavity. So that time I was on duty. I went there and then put a bagger mask, and luckily we could resuscitate the baby, and then the child became all right. The moral of the story is, you will not believe this has happened, because it was those days, it is only a nasal intubation, red rubber tube connected with the steel connector, that is a Miggles connector. I'm sure Balabhaskar or Chandrasekhar will know that you got a Miggles connector. What she did was, you removed the Miggles connector, and she did not remove the endotracheal tube, and she sent it to the ward. The tube got blocked, child at arrest. Luckily, it was the ENT surgeon was there, could take the tube out, and then if we could resuscitate, the child is all right. So what is important is, whatever it is, anything, this is almost the child would have arrested, and what will happen is, this has happened, but luckily what happened, the consultant was not terminated. The consultants were transferred from this maternity hospital to another hospital, which is the periphery hospital. That is the punishment. The child would have died, they would have terminated her job because of the fellow's problem, and because she signed. So a consultant should make sure that everything is all right before you sign it, because once you sign it, it becomes you are responsible when you are doing it. Then the third case, this has also happened in Saudi Arabia. Actually, I was I did from MD from Chandigarh, and then the pediatric surgeon, actually Dr. Saif, actually he's the first pediatric surgeon qualified in Chandigarh in 1982 from Chandigarh. From there he came to maternity and children. And I already told you, he's very happy with me, because you are from Chandigarh and all these things. There was one child, actually, luckily that child was an Indian child. Actually, this child was an Indian child. So he told me, Ramesh, usually I'm on duty. There the duties are from 8 to 8 in the night. And the morning 8 to 8 will come 12 hours of duty. And during the night duty, my head of the department instructions is that, because it's a maternity and children, you should not do any emergencies, especially in pediatrics, because pediatric emergencies can wait. And then if at all any emergencies, you go to the obstetric ward, see any pending cesarean is there, and make sure everything is all right. You cannot have a second on call. And if at all you want to have a second on call, only HOD has to be called. So what he said is, Ramesh, I want to do a pyloric stenosis, but I don't want to do with everybody else. Please, you come by 7 o'clock. My duty finishes 8 o'clock. So I will come by 7 o'clock, so that He finished pyloric stenosis. That child is only about 3 months old child, which is Indian child, which is quite okay. So I thought he is calling me, so I made everything is all right. That also, I'm not very expert, but I am better off at that time. 2 years of pediatric anesthesia at maternal children. I said I did it. I did intubation, and then after that, if everything was all right, then I extubated. At that time, there is one narcotic called buprenorphine, something like that. So I gave about 0.2 milligrams and all this. Everything was all right, and I extubated the child, and I gave at that time itself I was giving a lot of regional. So I was giving. Then I extubated the child. It was about 8 o'clock, and the child was all right and all these things. And then I went home. Home is maybe at about 10 minutes walk from the hospital. So that time it was fairly little new to me, but I didn't have a telephone. We have got what is called the pager. So we didn't have anything, but after about 8:30, I got a pager. Please come to neonatal ward immediately. So I don't know what to do. At that time, I don't have a car also, because it's not within about 6 months. I don't think we can buy a car initially. Maybe it took little time to buy a car. So I ran so badly from there to the hospital, and then went to the neonatal ward. Luckily, that neonatal ward is well equipped. The child became apneic. Then they intubated the child and ventilated. And after some time, they found that it is a little alkalotic. And then after that, they ventilated for 2 days, and then they extubated. I was really, very panicky. What is happening like this? So what the lesson I learned with the pyloric is that though the pyloric stenosis is a simple surgery, don't take it very lightly. It is metabolically, it's a critically ill problem. So make sure everything is all right. And then the child will be all right during the extubation. And once you extubate, the tube is the stimulator for this. And once you extubate, they become little apneic, and it's okay. So in pyloric, I'll make sure I don't give narcotic. I give local or a caudal, and then extubate very, very lightly. I don't hyperventilate. I hypoventilate, and then it's okay. Because the pyloric stenosis, the pyloromyotomy was invented about 100 years ago, but that is the same pyloromyotomy is being followed now, and their result is 100%. So I think we should not lose any child because of pyloric stenosis. So from that, I always tell this story to all the fellows. Please be careful. Wait for a couple of days, 3 days. Make it hypoventilate, and then you extubate very, very fully awake. See the half an hour, 45 minutes before you leave the patient. I think that's a real story of a pyloric. You must be very, very careful. You should never lose a child because of pyloric stenosis. Are you all right? Okay. Are you all listening? Okay. Okay.
Yes, sir. Yes, sir.
Yes. Okay. Is the volume is all right, Udupa?
Yes, sir.
Yes, sir. Perfect. Clear.
Very good. Okay. I finished Apollo Hospital, then went to Saudi Arabia. Then I came to Chennai again. Because I came to Chennai, I said I will do only pediatrics. At that time, I'm sure a lot of senior people will know Dr. Apukoti was there, and he was the director of this particular private hospital. He said, don't go anywhere else. Please come and join. He told me, tomorrow you come. He didn't talk to me about the salary. You don't know what is my duty or anything like that. Ramesh, you got something to do in pediatric. Don't go anywhere. Please join here. And then you will grow along with the hospital. I really happy, and I'm grateful to him because I have grown up the hospital. Everybody will say, you have done so much to the hospital. I always say, because of the hospital, they supported me. I am here for 30 years. Though we are fighting, but still we are okay, because without them, I don't think I would have done this. So I joined the hospital. I'm slowly growing. So after some time, what happens is many of the children outside our hospital also, many people used to call me for many surgeries. This, I think many people would heard in many of the airway conferences, which I have told you, because I don't think I will have another child like this, and I don't want to have another child also like this. This child is a 7-year-old child, came about 400 kilometers with a TM joint ankylosis, and all of them, they said they want to do a tracheostomy, and then they will do. And after a long time, I did a fibroscopy optic bronchoscopy workshop long time ago. The first workshop was done at Mangalore when US Ravindra was there for first IDA meeting at Mangalore. And so I was very okay to do a fiber optic scopy and intubate. And it was not in my hospital. It was in another hospital. So I took a fiber optic scope. I always took all these things, and then I explained to them, everybody, that I will try. If there's any problem, we might have to do a tracheostomy, and the parents have agreed for everything, and that's okay. So this is the child, the pre-op. And then I went, actually, whenever I go to another hospital, actually, this is Ram, who that time he was doing a fellowship observer for about 6 months with me at that particular time. Now he is an army consultant at Delhi, and now I think he's the HOD in the Delhi Cantonment Hospital. And I took him along with him. At that time, this hospital didn't have a sevoflurane. I took the sevoflurane also with me. I took the fibroscopy, and I always take one more assistant with me, and who knows, and he took with me. And somehow that time there's no camera. I put a fiber optic scopy, and then I was trying to do it with this particular child. And then I put the scope, and this I put this flexometal scope. I was very happy. See, it's successful. At that time, ETCOT was there. I found the ETCOT was okay and fixed nicely with this, and everything was all right. And I was happy, and the surgeon was very happy that I could put it, and he started doing surgery. After 1.5 hours of surgery, I lost the ETCO2. I lost the ETCO2. I try everything. I know that means the tube has slipped. See, this is what, the maxillofacial surgeon, they keep on pulling here and there, and that tube slipped. You can imagine this situation at that particular time, in the middle of the surgery. I can't do a real, it is in another hospital, the tube slipped, and then ETCO is not coming. I can't do mask ventilation properly because a lot of bleed inside, and all these things happening. The lucky thing at that particular time, believe me, that this is always say you don't have a sixth sense, anesthetists have a seventh sense. So I took everybody that particular time. That's where the Procil LMA was introduced. I took number 2 Procil LMA with me, and that time they could open about 2 inches of the mouth because some surgery was done. I was 2 inches of the mouth. Immediately I put an LMA. This is the child. I don't think anybody could have done anything at that particular time. And you can imagine, this is just lucky for me that I had an LMA at that particular time. Intraoral procedure was over. And then I put a Procil LMA, I fixed it, and this tube was stayed just to show you it's okay. You all must be wondering why. I see already the child is having no airway. I am in an hospital. You can bradycardic. What do you have to do? I thought that you may not have another child to show everybody what should be done at the particular. LMA has really saved my life. After that particular incident, what happens is he said, I don't want to do anything orally. I want to do anything extra orally. So what he did is extra oral bone graft was done with the rib graft and did the extra oral grafting, and LMA was kept, and then with ETCO was okay with the Procil LMA, decompressed, and it's okay. That particular time, if it is bleeding, you cannot do fiber optic scopy, you cannot put a tube. Only thing, tracheostomy, and that tracheostomy, by the time you organize with the facial-maxillary, I think we would have lost. So really, the child was really become bradycardic. I am become tachycardic. But I'm very happy that with this LMA, I could save the child. And this is the child immediately after the extubation. This is the child maybe after about 1 or 2 years. The child came after about 7 years, and then they told me, thank you, doctor, you saved me. Oh God, I can't forget you. You saved me, but I also told you, you saved me also, because I'm really happy that with Procil LMA. So I think that important thing is actually the Procil LMA or second generation supraglottic airways is one of the best, or one of the thing really the person is should be given a Nobel Prize for this, that difficult airways 90% of the time can be solved with a supraglottic airway device. Okay, this is another child. I don't have serial photograph, but I remember this child. I want to tell you this particular child. Okay. This child is about 5 months old child. Okay. This is 5 months old child. which is for hydronephrosis for pyeloplasty. Very healthy child, 5 months old child, 6.5 kilo, very healthy child. This child actually is to be done by the pediatric surgeon, was trained from abroad, and she came, joined new to our hospital. And you know, that particular time, the American people, most of them, they feel that they don't have to admit the people, and they have to come in the morning after good all the test has been done, and then they got admitted. And the morning about 8:30 or something, surgery, the child came, the surgery was posted at 11:30. So it's a new surgeon, it's a good surgeon, known to me also. So I thought she should be all right. So I went to the ER, emergency room. And in the emergency room, I saw the child crying a lot, and everything was okay. And mother was having the baby. I think this is maybe at that particular time. Actually, I remember this child because this was done about 3 days before the last Kannur conference, sometime maybe about 15 years ago. This is about 3 days before the Kannur conference. At that time, I was thinking, I am doing all these things, so that particular child is looking all right. Everything is okay. Investigation, I saw PTT, renal function, everything was okay. Crying well, pink and all. So I auscultated. Then I found there was a small murmur like that. When I auscultated again, there was a little murmur, but child was crying. I told mother, oh, everything is all right, and no problem at all, and all these things. So I asked the ER doctor, who is actually in charge, to auscultate. And she auscultated, and she said, no, it's a child crying sound. Everything is all right, no problem. You know, I can say a little bit of a forced at that particular time. That because a new surgeon, I don't want to disappoint. Child looks healthy. What's the problem? So I said everything is all right. So I took the child to surgery. I put in a line. Then I induced with that time Typentone. I put it a Typentone. I used at that time atricurium. Intubated the child, ventilated with nitrous oxide, oxygen, and isoflurane. I put the BP cuff in the lower limb. I put the saturation and everything was all right. I was using isoflurane, and everything was very good. Went on all right, no problem. And she was very happy. She's fast surgery, and then we finished within about 1 hour a pyeloplasty in a small baby. Then I extubated in the operating room. I extubated, the child is almost arrested. I extubated and child almost arrested. And said, what is the child is all right and all. When the child arrests a little, then immediately what I put the tube back and then ventilated and I auscultated, I found a big murmur. I could hear properly. Big murmurs were going on. So what is happening? I didn't know. So I asked the patient, the cardiologist to come. The cardiologist came, and then they found this all the thing that it is a PDA. Along with that, there's a coarctation of aorta. See, that's because I put the cuff on the lower limb, it's for normal blood pressure. If I put the limb on the upper limb, probably you would have seen the hypertension. So I put the lower limb, this one, BP was normal, and everything was quite all right because isoflurane is a very good vasodilator. So everything was maintained very well, perfusion because of isoflurane. And during surgery, everything okay. As soon as you extubate, lot of vasoconstrictions happen, and there is a coarctation because the child become failure, and because of the both duct as well as the coarctation. And you know, during the pyeloplasty, usually what we do is that because the pelvis is not dilated, we used to give some fluids. So we gave a little more fluids. That has created a lot of problem. And because isoflurane was vasodilated, we could give more of fluids. So we thought that everything was all right. Once that everything is over, vasoconstricted, then they created cardiac failure, then they then put PDA, and that. You can imagine my situation. Then I thought, see, what we should have done an echo at that particular time, pre-op and murmur. So it's really very scary. I could intubate this child, then put on a ventilator. Everything was all right. That particular time, we didn't have a cardiac surgeon that in our hospital. We had a cardiologist who came and did it. We didn't have a cardiac surgeon. So I spoke to the people and spoke to the parents. That's what happening. I'm going to transfer the child to the good center where they can do it. So it is about 3 days before Kannur conference and then all these things. So I went shifted to the Madras Medical Mission, and they did a coarctation, they did a duct within about 2-3 hours, then they ventilated for 2-3 hours, they did all the things after 3, then the child is okay. When the child was in another hospital, I came to Kannur for this meeting, and Kannur, actually Pankaj Kundra was my roommate at that particular time, and he asked me, why you're not all right, why are you not all right? But I didn't want to tell what I have done it, because it looks very bad to tell all these things that what I have done the mistake. But luckily that child we could transfer, we could find out, and the whole day I couldn't sleep. But I did the Kannur meeting. I don't remember. I think I did on URI and children or something like that. Then I came back and the child was all right. Just at that time, after that, I thought I referred to all the journals why this is happening. Then I found that within 6 months, the congenital heart disease will not be symptomatic, because they'll be murmur, the child will not be symptomatic, so it's very, very hard to do it. Probably what the thing is, then I was letting sutureize, I talked to the nephrologist, what's happening. Our own hospital nephrologist did a study of cardiovascular malformation with the urinary tract anomalies. This is nephrologist with our hospital, with the radiologist, did this study, and they found is about 60% of the children with the renal abnormality might have congenital heart disease. And then there is again one more article came, congenital kidney, urinary tract children, congenital heart defects. This says about 30%. Genetic link between renal birth defects and congenital heart disease. This is also showed, and all the things they say is that human congenital heart disease have associated renal anomalies. So after 1 or 2 years, it may be symptomatic. Below 1 year, 6 months, they may not be symptomatic. So the lesson is that before 1 year, if the child has got any renal parameter, we have started doing echocardiogram. I think that's a very important. In case if there is no echo, I feel X-ray. I should have done an X-ray at that particular time, and I would have seen a cardiomegaly definitely. Then I know that things are not all right. I think that's where lessons learned. And last about 25 years, I always do now echocardiogram for all pyeloplasty renal problem before 6 months, at least 1 year before the child. Okay. So I went to Saudi, I came back, I had a problem in this one. This is happened about 10 to 15 years after my child stress hospital. I think many would have listened it about this, but I also presented the same in the problem-based learning discussion in San Antonio, and along with the chairman of the malignant hyperthermia. This is a clinical presentation of a 12-year-old child and a female, 25 kilos, deformity of the back from age 1. And consulted many doctors, and non-consanguineous parents came for deformity correction, extensively invasive for Turner's, not conclusive. So they did all these things. The child was not able to sit, and it is really becoming very bad. So my surgeon said, all the things are there. Looks, we have to do something about this child. They asked a vascular surgeon also to come. It's a loss. It's okay. It's more like the back. It's a lordosis type. It's not really a scoliosis, and it's a lordosis type, which is okay. I said, okay, we can do with this. And we at that time, I checked the machine, and 18 gauge cannula inserted in the dorsum. We did an echo, pulmonary function, everything was normal, no problem, it is fit enough. Monitored pulse oximetry, NIBP and ECG, and then pre-oxygen of 3 minutes, morphine 2.5 milligram, thiopentone, articurium, isoflurane, and ventilator for 5 minutes. Then I sprayed the cords, and then I have intubated the patient. And spray with the xylocaine spray, intubated and connected to ventilator with the pressure control mode, and volume of, we got a volume of 250. At that time, we are giving 10 ml per kilo, but now I think we can reduce it to 6 to 7 ml per kilo. I connected, you can see this is the ventilator where we are showing this 250 ml pressure control mode. Everything is all right, 1 hour, the things are okay. After everything is all right, I had a fellow. Now with me is a very street smart fellow. Now he is a consultant in Ramchandra, but he's a very street, he's 1 year. I left, I finished, everything is all right, and they opened and positioned and surgery was done. And every time you, after some half an hour, you came and tell me, sir, there is something wrong, sir. The heart rate is going up, sir. Heart rate is going up. No, it'll come down, man. You need once this is okay. Give some more morphine. So he gave 1 more milligram morphine, and the heart rate is going up, and the heart rate is going up. After some time, he says, sir, temperature is also going up. Temperature is also going up. I told him everything is all right. I never knew all this. We have done so many scoliosis. It's okay. You continue this. So I put 1 more peripheral line, 18 LR, radial artery was cannulated, and temperature was inserted, nasogastric were inserted. Induction was at 8:30 and incision at 9 o'clock. I think about half an hour with all the lines and giving position incision is, I think that's a good time to give, even when at that particular time. And that particular time, actually, I went there and then I didn't know what to do. Then I remember the temperature is going up so high. Let us see the monitor. I found the trend at that particular time. You can see this one, which is 159. It went to 173 at 10:15. It also went about 10:30, 176, and all these things. Blood pressure was going up. 36.9, 37, 39, 39.7, 39.4. So this is at 10:30. All the things are becoming okay. And that you all must be wondering, so much monitor is there, why there is no ETCO2? See, this particular module, the ETCO2 was not working. So I didn't put that one, but suddenly I said I brought in another machine. As you can see here, this is what it is. This is the original machine, and then put the another one which brought the machine and put the ETCO2. I found the ETCO2 was 170. You will not, only Datex will show more than 150. It was 170. So this rise of BP and so much, I don't think 170 will happen to anybody except a particular country. It was 170, heart rate about 179, temperature is almost 40 to 41, and it is sweating, BP was rising. And I told the surgeon, see, this is at 11:23. From about 1 or 2 hours, it's happened like this. I stopped. I tell, please stop everything. It is the trend is the one which is going. Please stop. It is malignant hyperpyrexia. So I know this is what it is. And then he stopped. Luckily, the vascular surgeon was not only doing some. He has not really the vertebra has not been dissected and everything. So I said, please stop and just pack it. Let me check. No, it's not coming down. Please close it. So everything was closing. At that point, I know it's at that time I didn't have Dantrolene sodium. So I asked, I could find somebody. So what I did, this is how the closeout, you can see more than about 160. It is the one, and it started coming later with this particular. I'll tell you why this happened like this. So I warned the surgeon, stop the surgery, stop the inhalation agent, ventilate the hand with 100% oxygen, stage to new circuit, injection paracetamol 150 milligram IM. That time, you don't have an IV paracetamol was not available. Only paracetamol IM was available at the time. Cortisone was given, and we were ordered for the Dantrolene, because that time, luckily, I could find the telephone number, which is only about, the pharmacy is very close by. I could get the Dantrolene sodium and the diagnose. So got Dantrolene from close by, and blood gases, electrolyte, CPK test was done, and PHS 7.1, and PaCO2 was more than 90, serum potassium was 6.4, CPK was 2000. Immediately sent all, and then what it transferred to extubate. No, I didn't extubate. Transferred to the transferring trolley, cooled with hemotherm and ice cooling over the axilla, infused 1 liter of normal saline, and soda carb, bicarb 50 is given. Dantrolene arrived and infused with 40 milligrams of Dantrolene. Here I want to tell you about this particular drug about Dantrolene. Actually, this Dantrolene is this is prostalan. Again, this particular one is like it is like Baskin Robbins ice cream. I always compare it, because if you see the Baskin Robbins ice cream, you'll see the ice cream, but you cannot take it because it is so hard to do this. So what you have to do like this is that this is so hard. So dilution with this is, it takes long time, half an hour. So it will not be dilute, and you must see the expiry date, because half-life is probably only to about 3 years, which is I think that's okay. So it's really very important that you must have a Dantrolene by the time you were malignant hyperpyrexia. Luckily, we got it and then transferred to this particular trolley. We were doing at that time cardiac surgery. We have the hemotherm. This is a cooling blanket. I put the cooling blanket, brought down with the cooling temperature, put the ice blanket or ice purchase the ice bottles from the frozen one all over and try to cool and started giving this fluorine with the sevoflurane with this all the thing. That time no sevoflurane which was there, which is okay with that. So the lessons learned is, and then transferred to the ICU, ventilated about 45 minutes to 1 hour. Slowly the temperature came up and extubated and the child was all right. We have not finished the surgery and then we have sent the child back because he said we have to do something else. So the lessons learned for that is, if the ETCO2 would have monitored from the beginning, we could have diagnosed a bit earlier. We have stocked dantrolene sodium now at least for the initial bolus if MH occurs. So I think that's a very important. I think now it's available in many places, at least that particular time it should be available. So it's important that it can't be able to dilute immediately and give it. So there are some, this one, that after that we read the journals and that suits in what is called as the King-Dunborough syndrome. Actually, a lot of people I'm listening that it is a malignant hyperpyrexia. It will be very few actually has been proved it is malignant hyperpyrexia. I can tell you this is a malignant hyperpyrexia because the only King-Dunborough syndrome is the only one which is a proved MH syndrome. Because lumbar lordosis, then I found that King-Dunborough syndrome is lumbar lordosis with a short neck with pes cavus. This all I read it after of that case. Only few cases reported worldwide. Only 3 cases have been reported. All of them were diagnosed after anesthesia. None of them have diagnosed before. So I was happy that I also diagnosed only after anesthesia. If more or less synonymous with, if it is King-Dunborough, more or less synonymous with malignant hyperpyrexia. This is the child that King-Dunborough's photographs. It is like this child. So our child is exactly like this, and this is what I presented in the same San Antonio, that she was really very, that in the, I usually in the BPLD, we'll get only 10 or 12 people for the BPLD. I had 26 people in that particular one, and it was a very good discussion with that. So this is the paper, is anesthetic induced malignant hyperpyrexia in children by King-Dunborough, Journal of Pediatrics, 1973. This is the only reported ones. And this is actually dantrolene sodium, which is Procter & Gamble, which is doing it. And Eagle Pharma has got a Ravento. Both Ravento and dantrolene sodium is more or less the same. And it is, the half-life is about 3 years, but it is very difficult to dilute. And if you dilute that, what happens is it will, they were, fluid overload also can happen because you go 100 ml to diluted in each, and if you want to do about 10 to 20 vials in an adult, you'll get about 1 to 2 liters. So it's a volume overload, and this extra vesicator, there'll be a lot of necrosis. So you must be very, very careful in two things. So there is an alternative has come recently that is called the Raynaudose. This Raynaudose dantrolene sodium, which is a easily injectable suspension, which comes in a vial, which is easily diluted. 1 ml can be diluted with 5 ml of normal saline, and immediately you can dilute 1 milligram per kilo. You can give immediately. So you, instead of doing about 40 vials, you can store with 3 vials. But these 3 vials is supposed to cost about $7,000. 7,000, whereas that is only about 500, the 500 to $1,000. So what the paper has beautifully come, that is new malignant hyperpyrexia antidote, convenience, is it worth the cost? I think, except that it's very fast to give it, and we but the half-life is also less than that one, only 2 years. I'm not sure whether it's going to be really very useful, but in case you want to save the life, I think nothing like having 1 or 2, but it's very, very, very expensive even in the United States. Are you okay? It's about 9 o'clock. I think I'll finish this particular case and then I'll go to the last slide. Is that okay, Dr. Venkatagiri? I'll finish the last case. I'll finish this, and then if you want to, I'll finish this. It's
Please go ahead, sir. Please go ahead, sir.
I don't mind. You know, it's all only stories. If it's okay, I can. It's okay.
You can take up, sir.
I'll take up. Okay.
Yes, sir.
See, this is a child is done our hospital after some time. This is a pyloric stenosis. You can see the VGP, VIP coming, and VGP is coming like this. So this is a child which is a neonatal child, which is 3.2 kg. We did pylori myotomy, very well prepared, no problems. As you see here, that oxygen, halothane, that time halothane, 1 milligram atricurane, and orotracheal plain tube, 3 millimeter introduced, GA control, local infiltration, but analgesia just a local, 2.84 months, former preterm. It's a former preterm. After surgery, you moved all the 4 limbs, and after listening what happened in Saudi, I don't extubate, make sure everything is okay, and that's okay. After surgery, it moved all the 4 limbs. Everything was okay. It's all moving very okay. Reversed, spontaneous respiration, but a bit drowsy. So what is, because child is a bit drowsy, I having learned what happened in Saudi, I kept the tube and then the recovery room, and then I went for a cup of coffee and all these things, and slowly is okay. Within 30 minutes in the recovery room, become weak pulse, muffled heart sounds, and mottled skin, and fighting with the endotracheal tube. You can imagine child is actually very active, and child is mottled, very active, pulling the tube, and the child is having saturation is low and mottled. I don't know what's happening. Pyloric, we always expect something like some metabolic problem. But what's happening? Everything is all right. And what is your everything? I took it long time. Temperature is all right. What is the problem? I was not sure. So what happened at that particular time? Imagine that time actually I could put the stethoscope, and both the side I couldn't hear the air entry is not very good. So I don't know. That time immediately asked the X-ray to come. I took the X-ray, and the X-ray showed bilateral pneumo, which is unrelated to pyloric stenosis. So I was having a pyloric. This is the X-ray of this child where you got a bilateral pneumothorax. So what it can happen? How will it happen? I can't imagine this. It is okay with this. How can bilateral pneumothorax? All these things. Immediately we could. It's all happened in the recovery. We could put a 2 chest tube. There was no ultrasound and all at that time, but X-ray have to put in this one, and then put both the chest tube, and then this is the close-up of the same child with, you can see the pylori myotomy done, 2 chest tube has been put both sides, and then wait for some time, and then I don't know, you are sleepless for a long time. Then I was thinking what really has happened. Those time, we didn't have a lot of fellows. We didn't have, I used to do about 1 or 2 theaters simultaneously, and my technician. So I gave the bag. I found that I gave the bag to the technician, and then went for a cup of coffee and came back, and the technician doesn't know how to ventilate. Probably I thought he must have ventilated with bus like that, and both the lungs have been ruptured. I think that's a very, very important that's why there was a study by Kester Brown from Australia who told that whenever he gave a bag at that time to many of juniors and tried for 100 patients, and then came back and he found when he was ventilating at about 30 per rate. When he gave it to any of the fellows that they were ventilating about 60 to 100 per rate and giving a high volume. So never give the bag to the technicians and go. The lessons learned. The worst part of this is that actually this child has been done like this, and I told the mother, the child is all right. Some of this happened. I don't know why this has happened. You know what the mother told me? Sir, I also had the same surgery, sir. I never had problem in the lungs, and why this child alone have the problems? Can I tell that I gave the bag to the technician? This happened? No, something has happened. I don't know. Child is all right. Luckily, after about 2-3 days, slowly 1 tube came out, next tube came out, and with the 5 to 6 days, the child was completely all right. So I think this almost we have missed all the people. If we thought only thinking of metabolic problem, it was a respiratory problem. The lesson learned is don't always be like thinking one thing. Some unrelated complication can also happen unrelated to the same thing which is happening. I think that's a very important lot of lessons we learn. I think that's okay with that. I think that we'll finish with this. I'll just go to the last slides. Okay. Actually, this 2 I want to tell because only 2. This is very simple. I'll just be fast, but it's very, very important. This is related to Sunil's case. I was remembering this child. Actually, 10 months old baby for cleft palate and had BT shunt. And this is a BT shunt has been done. So 10 kilo baby, everything is all right, good weight. I thought we can do that. And then we started doing surgery, give fluids, and then no blood, everything was all right. And after some time, I went out, and the fellow actually given this, but whenever there's a lot of bleeding, we give tranexamic acid. And this fellow has given tranexamic acid, one because the surgeon was telling bleeding, and tranexamic acid was given. I didn't know all these things. And then after some time, then after that I came, and then after some day, extubated the child, sent to the room. And in the room, the child almost arrested. They called me, and then I intubated the child like what Sunil gave. I gave a little morphine. I know, then I put the stethoscope. I couldn't see, the murmur was not very well heard. That means I thought there's a shunt block. And then I found out that she is giving a tranexamic acid. Instead of giving a lot of fluids and hydrate the child well, and you are giving a tranexamic acid, so you got thrombo. The child went into a TET spell and the shunt blockade. Luckily, we got something. We ventilated, give a lot of fluids, and then we give a morphine, then paralyzed, and given oxygen. As he's told, they're given hyperoxia, because immediately we increased the inotropes, brought to the theater, and called the surgeon and revised the shunt. So it's important that when you are giving anything, please think what you have to do and pathophysiology, so that you don't get into problems. Okay. Having done that, I think in this particular era, I thought I will not tell about the COVID, but I think this you must find. This is what we call the first one. It's called COVID miss. For last 3 to 4 months, I have not done any cases by myself. It is okay. So I thought I am more than 62, and I have diabetic as well. So I don't want to go and do any cases, but I do little administrative work. This child is a cleft palate child. This is a cleft palate child, and also it has been made a 10 months old, 11 months old child, and both the parents were doctors, and their relatives were doctors. And the pediatrics, the plastic surgeon said somehow the child wanted to get it done, sir. So many problems are there. They're very keen. And so with all the whatever this one, he has done one COVID test before. After 1 week, he got another COVID test for the child, and both the child are negative. And because they both are doctors and mothers, both the doctor and mother were also done it. And I made sure that we did one video conference and all these things, and nothing has been done. I did full PPE with the full PPE, with full face mask, with all the filters, all the gloves, with all the intubation, with the plastic sheet. Everything was done with the cleft palate, and only 2 people were allowed. After that, only the person with the surgeon was allowed, and he did. And then after that, after intubation, I came out of the theater. I didn't go for 1.5 hours. All extubation, everything was done by the fellow only, because I didn't want to go inside, and everything was all right. Child was all right. And then the same night, evening, the child was discharged also to home. And then after the day of surgery was done and sent, and that day was over, next day morning, I getting a call from the plastic surgeon. Sir, sir, you did that child. Whenever I get a call, I got scared. We did the child. The child is all right. What was the problem, sir? I asked. No. The child is all right. The problem is, next day I went to my hospital. I found one of my friend is positive for COVID. So I did COVID test for me, and that become positive. So you all please be careful, sir. You be positive. Oh God, I tested for everybody, and I tested for all. That means when they're coming, I have to test a technician, nurses, and everybody. Then only I can go. You can imagine the surgeon telling me that it is okay. He's asymptomatic, and luckily at that time you will not believe. He put one N95 coming from home, and you put one more N95 over it, and then he operated. So I was very happy, because he had the source of infection was very less. So I was very happy. And then after about 14 days, I never went to hospital. I made sure quarantine, morning betadine goggle, evening betadine goggle, morning all things, whatever given in the WhatsApp, I did it, so that to do all these things. So it's very, very scary these days. Not only that, today I got no news. Everybody, the breaking news, we thought, this is the WHO, I don't know what, that's really a lot of stupid things are happening with WHO and the ICMR, all these things. The breaking news is telling that COVID-19 is confirmed by airborne and remain 8 hours in the air. So everyone is required to wear mask everywhere. So we never thought the airborne is only droplet. Now today, this happened in about 6 o'clock with this airborne. That means no one can go outside. That is the biggest thing. It's okay. Even in the family, each one in each room, everywhere. It's a really very scary situation. situation, and today it will be there, tomorrow I don't know what they're going to tell. Very situations very bad, and somehow I have escaped from the COVID. I think so. I don't know how long I can get escaped, because it's okay. Young people are doing this. So I just want to conclude with this, that good judgment comes from the experience, and the experience comes from the bad judgment. But you don't know, whenever there is like this, if nobody knows who has done it, we'll write like old Chinese proverb. So I don't know whether it's an old Chinese proverb or it's the Shakespeare. I don't know who has written this, but you will always be right if you write old Chinese proverb. Thank you very much. Thank you to our Balabhaskar. Thank you, Chandrasekhar, to everyone who has listened. I hope I have given whatever the misses. I don't want any more. I don't want to miss any more, because very few years are left for me, and I don't want to wait more. Thank you very much.
Thank you very much, sir. Thanks a lot for sharing your experiences of near misses. In fact, before I start taking the question, I mean, real academic questions, there was a post by one of our colleagues. He has asked, sir, don't put near misses, but put clear misses. Not near misses, clear misses. Okay, it's all
Wonderful, sir. I
I
muted and kept quiet. I did not respond when you were talking.
No. There's no problem, sir.
You told me, I just showed the message.
See, I'm a very bad, because I don't. That's why I see. For example, these are all been collected for last about 30 years. Are all personal problems. I don't want to record. That's why I told you. So I don't want to record and go into some the fellow who has done lordosis may see somewhere else, and he said this is my face and all these things. It's not really very good. It's very sad, but I don't mind sharing with the problems. That's why it's okay. That's why I told Udupa and also Venkatagiri requested, please don't record this, because it's all experience. A lot of things are happening, and I don't want to be recorded. And especially the plastic surgeon who came along with the COVID positive should not listen again. Then you will be very unhappy with me. So I don't want to record. That's why the recording was stopped, not for nothing else.
Okay.
No, for question.
Yeah, Dr. C.R. Chandrasekhar. There are just around very few questions. You have anything to say and put some questions? Yeah, you can just start.
It is this greatness that Dr. Ramesh is kind enough to accept that these things do happen in OT. I would like to share one of my experience in when I was in Indira Gandhi Institute of Child Health, where we had a child which is come for respiratory distress, has gone to so many hospitals, but everybody did this thing, DL scopy, and there's nothing. But father is very adamant that child has swallowed a bone. He went to neighbor's house and swallowed a bone, but they did scopy and they said nothing. So they were referred to a chest disease hospital. We go there. On the way, they saw our Indira Gandhi Institute of Child Health. They came, myself and our surgeon. His name is also Ramesh. So we were all about to leave. Then just saw the child. Ramesh said, "Hey, there must be something wrong. Child is pale, gasping." So we immediately, without even admitting child, we took the child to the operation theater. We had a side room where we used to do small INDs and other things. I was just holding mask. Saturation was very low. Then meanwhile, we arranged for admission, and Ramesh was ready for bronchoscopy. I was holding mask. Saturation gradually improved. This thing we accessed. We gave a little bit of Bidas Fenta. I just tried ventilating. I was able to ventilate. So then Ramesh said, "You are ready. Just give me some relaxation. I can go in. We'll see what is there in the bronchos." So at the moment I gave scolin, a low dose. Within seconds, I was not able to ventilate. Then he said, he tried with his rigid bronchoscope. He says there is something whitish structure between the vocal cords. He is not able to push the rigid bronchoscope. Then saturation started falling. Anyhow, child neck was extended. So immediately I took the knife. This is one of the incidences where somebody says, cut the throat. I had to just slash the throat, and I was able to get this thing. I pushed a endotracheal tube below into this thing, we were able to ventilate. Meanwhile, this saturation, heart rate, everything improved. Then I took out the endotracheal tube. Ramesh was able to go inside and see below. He said there is nothing below. So he came back and see the upper portion. He says there is a bone which is fixed, which is across the vocal cords. What would have happened was, we thought, which was slightly loose when it was there, after relaxation, it just got fixed below the vocal cords. These are one of the few instances where all postgraduates should know that somehow get into trachea. See, either you need cricothyroidotomy needle or whatever it is, by any means you get into the airway, secure the airway, and you can save life. See, this is one thing which I still remember, that I was so careless about this thing. Just we had to slit the throat and get into the trachea. So there are so many instances. I think Ramesh should come out with a book, Mrs. in Anesthesia, so that everybody in the audience and this thing can contribute to this. Thank you, Ramesh. Thanks for your wonderful talk.
Chandrasekhar,
Yes, sir.
I don't want to write a book for what all mistakes I have done. I don't want to write a book, sir. You tell me that let a good book I can write. Why do you want to write all the bad things in a book, Chandrasekhar?
No,
Sir,
dear
sir, one of the question to Dr. Sunil, sir. Dr. Sunil.
Yes, sir. Yes, sir.
Yeah, Dr. Sunil, there's a talk. Is antifibrinolytic safe to use in single ventricle kids with BT or a Glenn shunts?
I understand the concern, sir. The question is because the shunts are precious, and intensivists avoid procoagulants because they have the potential. Procoagulant situation has the potential to block the shunt. As for BT shunts, I don't advocate elective surgery in BT shunts at all, because the careful balance of SPR and PVR is difficult to get, and you can't afford to get it wrong. So surgery itself is a procoagulant state. So I would avoid elective surgery in BT shunt. Then that said, tranexamic acid is to be used electively when there is polycythemia and altered coagulation function. When the risk of bleeding is excessive, either because of the nature of surgery or because the patient was on antiplatelets, tranexamic acid should be considered. Actually, good hydration, maintenance of preload, and cardiac output is important for shunt patency. Low cardiac output and dehydration, they promote stasis, and that's what promotes shunt thrombosis. Anyway, if there is coagulation dysfunction, we cannot afford to lose a lot of blood in preload dependent lesions, cardiac conditions. So the risk versus benefit has to be balanced. Anyway, it can be used in Glenn shunts and Fontan, where the risk is not as much in a BT shunt of getting blocked.
No, you are telling that if there is a BT shunt, you don't want to do an elective surgery. That means you have to do a total correction, then only you have to do the other elective surgery, is it?
Yeah, the next stage of palliation should be done. The Glenn shunt should be done. BT shunt is palliation stage 1.
Okay.
Next stage of palliation should be done, a Glenn shunt, before we progress to elective surgery.
So if there's a cleft palate, I should have postponed that case?
Glenn shunt can be done after 4 months, sir. Cleft palate.
Okay. So if there's a child with a BT shunt with a cleft palate, I tell them you would go have a Glenn shunt, then we'll do the cleft palate.
Sir, that would be safe, but a cardiology consultation for the lesion regarding the shunt. Some shunts are very small when they are placed, because the pulmonary artery size is so small, the shunt that can be placed on that vessel is also small. That kind of shunts are liable to get blocked.
Okay.
So all the factors needs to be weighed in. All in all, I would be very say that. Yes.
Yeah, that's right, sir. That's I understand. That's why you see, as a pediatric anesthetist, I don't do cardiac, but for us, we all feel that if the child has a cyanotic spell, that the BT shunt, now it has been palliated. Now the child is okay for doing elective. That's the picture we get for all, because you are aware of a lot of other problems, so you are able to really say what exactly. But if there comes like this, I always consult a cardiac anesthetist before I take up this case, that whether should I take it up or not, because he's also a good friend of mine. So I all call them, this is how it is, because as you understand that, every specialty is entirely different. What you are talking about is entirely a different type. Otherwise, as a person who is a non-cardiac, we always feel that, a child is cyanotic spell, just do the BT shunt, it's ready for any elective. After doing that, they can go for a total correction, something like that. It's good to have some cardiac anesthetist as a friend if you want to do something like that. Okay. Thank you, sir.
Thank you, sir.
So there are some 2-3 questions, Dr. Sunil.
Yes, sir.
I think you had tried to answer in the chat, but let us open it to the audience also. Let them also listen.
Okay, sir.
So one question was about by Dr. Hattu, sir, why is spontaneous better than positive pressure ventilation in Glenn shunt?
Glenn shunt is a passive shunt.
Postgraduates, yeah.
Glenn shunt is a passive shunt, and Glenn shunt means the superior vena cava is connected to the pulmonary artery. So there is no pulsatile flow through the Glenn shunt. Passive venous drainage occurs from SVC to pulmonary artery. So SVC is the upstream pressure, and the downstream pressure is the pulmonary artery pressure. And the pulmonary artery is intrathoracic. So in positive pressure ventilation increases the intrathoracic pressure. So drainage cannot occur if the downstream pressure is higher. So spontaneous is better. It's because it's a preload dependent condition. Saturation depends on the getting a good preload to the, through the pulmonary arteries.
Okay. So related to your discussion, Dr. Rajesh MC has put a question, but what about a combination of STP and ketamine instead of opioid and ketamine?
I have no personal experience with combining thiopentone and ketamine. I am suspicious of both thiopentone and propofol in cyanotic congenital heart disease because they can produce a sudden decrease in preload. But I suspect Rajesh himself has some experience with this combination. If so, I would like to hear how that works out. But I have no experience. I don't use either.
Okay. Rajesh, Dr. Rajesh, you are online. You can just take a moment. Dr. Rajesh is there, Dr. Udupa, Mr. Udupa? Okay, I will go to
there,
the.
but
Is
I
there?
think, is there?
Is there? Dr. Rajesh?
We'll go to the next question, sir.
Okay, we'll go to the next question.
By that time, Rajesh.
By that time, he'll be back. Pre-medications and role of dexmedetomidine.
Dexmedetomidine is a good drug. We use it in our cardiac surgery unit by ablating sympathetic response, reducing the amount of opioid and sevoflurane that needs to be used. It can be very beneficial. I would use it. I would recommend using it.
Yeah, with respect to the heart rate responses, you are happy in cyanotic diseases?
Cyanotic heart disease actually benefit with a lower heart rate. Lower heart rate means more diastolic time. The ventricles fill a lot more. And when the ventricles are filled, they are well filled, the shunt can actually turn a little more left to right than wholly right to left.
Okay.
So
what? Okay. That's a benefit and can be used in a judicious manner, right?
Yeah, it can be used in a judicious. I would probably avoid the bolus because that can produce sudden decrease in heart rate, which may not be very good to have all of a sudden decrease in heart rate. Many tetralogy of Fallot patients are electively put on propranolol, so that also has to be, that factor has to be weighed in.
Yeah, it's a dangerous combination, right?
Then it's a dangerous combination.
Okay. For a practitioner in general, what would be the factors to be considered when incidental surgery like laparoscopic procedure is taken up?
Yeah, laparoscopic is a particularly dangerous surgery because it dramatically decreases the preload. It requires a head-down position. That's a very tough surgery. There is very little literature on it. I have no experience either of doing it or reading about it, but or everything I have read has cautioned against use of this kind of surgeries. If anybody has experience doing it, I do not know, but if that is undertaken, all invasive monitoring should be taken, including an arterial line and a line that can administer volume quickly.
Yeah.
So that even if the trial works out bad, the child can be quickly resuscitated before I mean, it may have to be abandoned midway. That should also
Dangerous,
be factored in.
That means that if it is indeed decided, it should definitely be doing in a cardiac center only.
Yeah, in a
That's
cardiac
most
center,
important.
absolutely.
And Dr. Rajesh is here. Rajesh, can you give your input with respect to use of thiopentone with, with ketamine instead of opioid and ketamine? You are there, Dr. Rajesh? Can you hear me? I can see your face. You are unmuted. You can talk. Dr. Rajesh?
His network bandwidth is low.
Appears to
Dr.
be low.
Rajesh? Yeah.
Dr. Rajesh, you can stop your video, then we would be able to probably mobilize some speed to. Okay. Am I audible, Dr. Rajesh? Okay, there appears to be some issue. And anyway, there is probably one question to Dr. Ramesh, but before that, to Dr. Sunil, for a smaller setup, is there a broad clinical guideline or an indicator of when the practitioner should not attempt to manage a patient in the periphery and when he should decide to shift to a higher center or get for send for consultation?
Consultation is a must before before congenital patients.
Yeah, minimal opinion in the form of echo or whatever.
Whatever.
For surgery aspects, non-surgical procedure, I mean non-cardiac procedures.
Consultation both with the cardiologist as well as Ramesh sir has said, with the cardiac anesthesiologist is also essential, because cardiologists most of the time, if they are not specific pediatric cardiologists, are not aware of many of the risks associated with either the condition or the condition after the palliative surgery. For example, they may not know the kind of anesthetic implications a gland shunt has, because they don't deal with a gland shunt on a ventilator. They see a gland shunt coming to the OPD and they do an echo and that matter ends there if there is no other thing. But a consultation with the cardiac anesthesiologist will provide all these inputs. Try to go for a spontaneous or when you ventilate, go in for a mode that has lower airway pressure. Don't use too much PEEP. Keep the patient head up for a gland shunt. So a consultation with a cardiac anesthesiologist is also essential. In general, patients who are very cyanosed, who have a hemoglobin in excess of 20 grams per deciliter, they are in cardiac failure. They have a suprasystemic or near systemic pulmonary arterial pressure. Those cases should not be taken up in a center where a cardiology review or immediate echo in the OR is not available.
So we have got Rajesh online. Now, can you listen to us, Dr. Rajesh? Dr. Rajesh, can you hear? Okay, it is persisting. Sir, Ramesh sir, one of these, very frequent miss still that would happen in practice is the tongue tie related procedure. So you can just convey the importance of the care, the standard of care that is required in this small procedure, but of a big risk. It's a huge risk.
Yeah.
Yes, sir.
Actually, there is a lot of I was preparing a lot of talk. I had a lot of like that. There was a lot of difference between what happens at critical incidents. There are a lot of critical incidents happen to us. I'm not talking about. I didn't talk about really critical incidents which happened every day. So that has happened to everybody, to you juniors. Critical incidents are that is almost. I don't think anyone will say that I didn't. I don't have.
I didn't face. Yes.
Critical incidents patients are different. What
Yeah,
I
yeah.
was talking about, almost we are losing and somehow saved with certain things. That's
Yeah.
so I was just thinking of what happened in different places and whatever, instead of talking something which I got some evidences to show and what I learned from that. So if it's a near miss is something little different from the critical incidents. That's what I did it. But tongue tie, actually, this is a very important to everybody overall listening. There is nothing like many people will say it's they will come and you know what the surgeon will tell. No, you just a small thing. You go there, I will just cut it. So nothing will happen. No problem. So the patient will come for assessment, and as I will tell everything, immediately the patients will tell me, no, they told me, sir, nothing a problem, but you are telling anesthesia and you are telling all problems. You just have to cut it. It's a small thing. See, that's why I always everybody the same thing happens to this one. The analog I always tell is, no, I am traveling from Chennai to Coimbatore, or you are traveling from Chennai to New York. There is no difference in the risk. It's a risk are the same, whether it's going from Chennai to Coimbatore or Chennai to New York. So it is a minor surgery, but anesthesia is always a major. And as you are telling me that most of the problems occurs in the minor surgeries, where most of the major surgeries they accept. Like, for example, cardiac anesthetist and neuro anesthetist are, Sunil will be very happy. They always say that the heart didn't pick up. So they will be very happy the heart didn't pick up. But we cannot say the heart didn't pick up. See, we are finished there. So it's better to be a cardiac anesthetist or a neuro anesthetist. Because the neuro anesthetist, they know that when they come to neurosurgery, if they come out, they're very happy. If they're not come out, oh, brain is gone. So it's all okay. So I think that's how we take it for tongue tie. We are finished. I think that's a very, very important, that never underestimate tongue tie, sir, because tongue tie, many times they put an LMA and middle of the surgery, they pull the tongue and then they extend a little bit, then immediately the LMA will come out, then there is no line. Some people have done, they'll say a little bit of diathermy and cut it without a line. Those things are all very, very scary situations. If you tell me, for anybody who are even experienced or something like that, and everything and all the thing, I feel that tongue tie should be intubated. I think that is the most important thing. The tongue tie should be intubated because it's a very, very minor procedure. And any medical legal problem, I always tell them, if there's any medical legal problem, judge always say, if the problem has occurred, if the child have not done the tongue tie, will that be a problem with the rest of his life? There is no defense for us. So I think that is the situations where we should be very, very careful, that we should put in a tube and then it's okay. LMA is okay, but LMA can be done only if you are very good in putting in LMA and your surgeon, you know what the surgeon is doing, and you are very senior fellow to stop, and then you put a tube and you agree that you are doing. If a junior fellow, the surgeon will say, please don't worry, I'll finish in 2 minutes, I'll finish in 2 minutes. So I think that's why you will be very careful in tongue tie. I think for tongue tie, you must intubate. This is I think that's airway should be secure for a tongue tie.
Yeah, there should never be any alternative. That should never come to our mind.
I think so. This is everybody. Sometimes I do a little bit of put an LMA and see whether. But our surgeons are very clear, and I, as an experienced person, I'll keep watching. The little before you get in a problem, I said, please stop. Things are not all right. I'll put the tube. I think I have done something with LMA, but I am careful. But I will not tell anybody else to for a non-pediatric anesthetist to do a tongue tie without tube. I don't advise.
Definitely not advisable. In fact, Dr. Anand Bangira states in a facial-maxillary case with accidental extubation, where you try to use supraglottic airway device as a rescue, you need to have such a great courage to continue with surgery. So trying to make courage is always dangerous than trying to act wisely. So that's another take home. So never think you are never be complacent and overconfident, but go back to securing the endotracheal tube with the endotracheal. That's most important consideration here.
No. There, it is not a courage. I want to tell you that it is not a courage that, I don't want to be brave. It is not the question of brave. But see, now what happened is that, what happened is at that particular moment, already rib graft is already taken. It's ready right now. And whatever the intraoral is over. But now with intraoral, I put in an LMA. And then after LMA, I get everything is all right with that, so there's no problem. So anything he has to do only the external, and then he fix that. So it is not that brave, but if the things are not all right, I would have said, please just close it. I will put the graft later. But everything I waited for some time. I know the airway is okay. I can put an LMA, and in case there's necessary, once I put an LMA, I can put a bronchoscope through the LMA. I can put a tube also. So I got an option to left for that particular time. It is not the braveness. It is just the not the courage or braveness, but I use my thinking that it can be proceeded and I can be safe to do that because I can open 2 inches. So that's a way. If I not put the tube, I would have just put a mask and try to ventilate a little bit, close it. Let me see if the child is awake. I would have sent it. We'll do next time. So that is not the question which is happening because I know I could open and then put the tube. The surgeon never forced. He's a very, very, very. So most of the time we work together. That's not the courage or braveness.
That coordination is very important.
Yeah, that's
trust in each other's abilities.
Yeah, that's it. It's nothing to do with the NDs.
Okay. So just now, I mean, we'll just take up this. Dr. Rajesh, anyway, we were not able to connect. So he has given his opinion in the chat. He says, we used to give a combination of terpentan, sodium and ketamine before the era of etomidate or short-acting opioids for emergency procedures for brain abscesses. Yes, that was the way we could do, Dr. Sunil, prior to the advent of etomidate and safer practices.
But I have a preference for ketamine. I suspect a lot of anesthetists have the same preference as me, but this thiopentone, I have some experience combining propofol with ketamine as infusion in cardiac cath, for cardiac cath. Then also I don't bolus propofol. I prefer to bolus ketamine to start it off. Then we have used ketamine plus propofol infusion for the cath lab procedure, taking about an hour or 90 minutes or so. One more thing, I agree with the sentiment expressed by Ramesh sir with regard to cardiac anesthesiologists, but I would like to modify it a little. Anesthesiologists who are anesthetizing cardiac cases for non-cardiac surgery, they have a big task on their hands. The patient comes with this cardiac condition for a non-cardiac surgery. At the end of the non-cardiac surgery, and during the non-cardiac surgery and at the end of the non-cardiac surgery, the patient will be having the same cardiac pathology. Unlike a cardiac surgery, he enters with a cardiac lesion. At the end of the surgery, the lesion has been addressed. Whereas in non-cardiac surgery, a lot of things get done to the patient during the surgery. He bleeds, he gets bank blood, his SVR, PVR is all being altered, either desirably or undesirably. And at the end of the surgery, his lesion is the same. So the risk is more, the outcome, the likelihood, the morbidity tends to be higher and the responsibility is more. So the sentiment is right. And besides, when you anesthetize for non-cardiac surgery, the surgeon at the end of the procedure will innocently say everything went well with my surgery. I mean, if the patient has tetralogy of Fallot or normal heart, the surgery for an abdominal procedure is the same. You'll say nothing wrong with the surgery. Unlike that, in a cardiac surgery, the surgeon is part of the team. Any problems arising within the anesthetic or surgery is a common problem. So anesthesiologists have a big task on their hands while anesthetizing patients with cardiac conditions for non-cardiac surgery. I agree with the sentiment.
Dr. Sunil,
Yes,
this
sir.
is just a corollary to what you said. It's a very important, because what's happening, the same corollary to what you have said, the people who would have done multiple cardiac procedures, all right, they would have done multiple cardiac procedures, and then they will come for hernia to our hospital. And what they're feeling is that even cardiac surgery they've done well, why can't you do hernia for anesthesia? When you tell that when anesthesia risk is more, no, cardiac surgeon, cardiologists have said everything is okay. The same thing, cardiologists think everything is okay. When I'm not okay. What is this happening like this? Because cardiac anesthesia, cardiac surgery under bypass, full monitoring, and you put all the PFO, Swan can say whatever you want, you put monitor. For hernia, I can put all monitors, put on bypass, do hernia. So I think the situation for them. I many times for last 30 years I had the same doubt, because these days all congenital heart surgery you operate, they're all doing very well thanks to good pediatric cardiac surgeons and everything becoming all right. They come for all lot of non-cardiac problem after the cardiac procedures. So they always tell me, sir, my cardiologist said everything is okay, sir, and it's okay. See, once the heart is touched, done some surgery, the myocardium is not normal as it is in a normal patient. That is, this is my conclusion, that once you have touched, gone on a bypass, done some surgery, you've done like total correction of ventricular fellow. That means they feel that it is completely corrected. But the ventricle are not all right, the bundle branches are not all right, so it may not be something. So I think it's a very, very difficult situation to convince them that this is also a risky procedure for a non-cardiac procedure.
Yeah, patient education by cardiologists remains very poor. Patients sometimes do not know they have received only a palliative surgery. They think a corrective surgery has been done on them, and it has not. When that is not the case, patient education is lacking. I agree.
Okay, so, Dr. Giri, is it okay? We are under just 1 or 2 questions are there, or is there a time?
I think we can proceed with the questions. Giri sir is not
No,
there.
sir. Okay, Vinil.
Yeah, sir. We can
One more
Okay,
coffee,
right.
sir. So one more coffee if you want, I can give.
You want a project?
That's all I can do, sir.
No, you have to send 100 copies.
That also I can
I am
give.
very much there.
Okay, good. So what has happened? Yes, Giri. So there are some.
I am very much sorry. I proceed and ask. I have just muted my both video and audio, and I am very much there.
Okay.
Please.
There are slightly. Yeah. So one to Dr. Sunil in duodenal atresia with. Okay, no. Right. Is it? I don't know. I am getting confused. In duodenal atresia with TOF, how to proceed? When to do shunt? When to do duodenal atresia? So he's talking of tetralogy fellow. Or okay, Dr. Sunil, you can take it.
Yeah.
In
See,
duodenal atresia.
I have not seen this particular combination.
Yeah.
So duodenal atresia has to be addressed immediately. Am I right? I mean, tetralogy, depending upon the condition, can wait. Not every TET is rarely ever operated before 6 months. For complete correction.
It's a real emergency, neonatal emergency.
So it's a neonatal emergency. It's an emergency. It's not an elective case. So a cyanotic does better when he's operated after 3 months. Routinely, they are operated only after 6 months. So you have to go ahead with duodenal atresia and face the consequences.
Okay. Ramesh sir, it is not related to near misses and all. There is a general question. What strategy you would adopt in case of syringing and probing in children?
Okay, it's more or less. I think it's more or less little more better than tongue tie. Little more better than tongue tie. But I think it is the management is syringe and probing is will be more or less tongue tie. But in case you are a little inexperienced or little, I think the safest is endotracheal intubation, because sometimes they say little syringing, but it will be little more than 50 ml, 100 ml. By the time the syringe this side and that side, it might become more. So you may be little more careful when you are really syringing. But if it is syringing and probing, LMA is not very bad, because they're not going to do anything with the airway. So what you can do is put an LMA, will prevent the aspiration. It's not a problem. But LMA with a good analgesic, because syringing and probing is a very, very painful procedure. So you need a good analgesic, and LMA is not very bad. In case if you are not able to have a second generation supraglottic airways, I think the choice will be endotracheal intubation for syringe and probing. It is not those days syringe and probing is a very simple. Now the syringe, they'll put a list of syringe and probing, they'll bring an ENT surgeon, and then they'll put endoscopy through the mouth whether things are all right and all these things. It is not like those days, just a syringe and probing. If the dye comes out through the nose, they say the syringing is good. Now they don't do that. Sometimes they come with the ENT surgeons, the big, it comes about 45 minutes. I feel if it is the safest is intubation, not you are little more experienced, you can do with an LMA. LMA, you don't have to really, LMA, you can put a small throat pack, because the throat pack will keep the LMA in the position in the place. I think the choice will be in LMA intubation, and little experience with LMA will be okay.
Would be second generation. Yes, sir. To Dr. Sunil.
Yes, sir.
Because some conditions may not be symptomatic in the beginning.
Yeah.
There is a question from Dr. Jayanti Shripati. Do you recommend an echo in babies less than a month, a term baby, as pre-op evaluation? Because we get many cases for daycare procedures.
Daycare procedures. A clinical exam itself is enough. Evaluate for murmur, room air saturation, and so on. But one point Ramesh sir said earlier, many of these left to right shunts, cyanotic congenital heart disease will be evident. They will not remain asymptomatic at 1 month. But left to right shunts, ASDs, VSDs, and PDAs, they do not manifest with cardiac failure until about 3 to 4 months. This is because immediately after birth, the pulmonary vascular resistance tends to be higher. And that comes down over 3 to 4 months. That's when the symptom starts, the manifestations of cardiac failure, the tachypnea, the sweating, all these things take that much time to develop. So they may not be overtly manifest as symptoms, these left to right shunts, large VSDs and PDAs, but they would be having the murmur, even if not that kind of florid murmur, they would still be having that murmur. So asymptomatic babies for echocardiography is not advocated. But a careful clinical examination is a must, and further investigation based on that is required. You're more likely to miss a cyanotic congenital heart disease, not cyanotic congenital heart disease.
Okay, that's it. Then just a corollary from Dr. Rajesh. Comments regarding transnasal dexmed for cyanotic babies for outside OT procedures such as MRI suite.
Transnasal dexmedetomidine, I have zero experience. Rajesh himself has to answer that. Once again.
Have you, sir? Ramesh, sir?
Actually, one of the very good, actually that transnasal dexmed is one of the very good for all this very good procedures. Actually, there is a, if you have a, there is a nasal spray which is available, but very difficult to get in ear. But what you do is you take in nasal spray, take about 0.1 to about 0.5 milligrams. You can take it in an insulin syringe, and then take in the insulin syringe and then put in both the nostrils 1 ml, 1 ml. The child is quite okay. Within half an hour, the child will sleep. It's a very good pre-med. But this COVID condition, we don't give any nasal pre-meds at all. Not this particular situation, we stopped giving any nasal pre-med with dexmed. Otherwise, dexmed is actually initially, I think Dr. Sunil, initially they were all very unhappy to give dexmed for any of the procedure for cardiac. But a lot of papers have come that dexmed is very good, especially especially with cyanotic. We want the heart rate to be a little more low. Those days, halothane was a very good agent because you can increase the rate. Now with halothane, I think dexmed is good. Dexmed, I think dexmed transnasal is a very good pre-med and also procedural sedation. But at this particular level, we should, I think we should avoid any intranasal pre-medication.
Yeah, aerosol generating procedures.
Yeah.
Thank you.
Yeah. I think we have, it's 9:40 now.
Yes.
And coffee will not suffice further now.
Beer, sir. Beer. Yeah.
Okay. So I thank Dr. Venkatagiri, the President-elect of ISA National, Dr. Nazar, the President of ISA Kerala, Dr. Binil Matthew, Dr. Chandrasekhar, a pediatric anesthesiologist who was here. Thanks to him also. And the two esteemed speakers, of course, Dr. Ramesh and Dr. Sunil, for having given and shared their wisdom. Basically, that's more important from Dr. Ramesh's point of view, near misses, and the knowledge from Dr. Sunil. That was very great for today's session. And I also find a lot of senior members, including our past presidents, Dr. Chakra Rao, Dr. Kameshwar Rao, then GC members, including Dr. Kiran are there. I think more of our colleagues are there. Thank you very much for participating. Now over to Dr. Giri. Thank you very much.
Okay, thank you very much. It was an honor for us to hear Dr. S. Ramesh And Dr. Sunil also very nice. Though Sunil is our own man, many times I was not much hearing about him. Very, very nice talk he has given. Wonderful. The presentation was a beautiful presentation. Ramesh, I need not say that it is wonderful every time. Thank you for mentioning my name from the beginning till the end. It was honor that you agreed, because I was trying for last 2 months because he had committed to other two. He could not, but and more than that, he was present in almost every webinar which we conducted from Kerala. For that, I should thank him very specifically, and thank you very much for that. And there are many delegates who are very particularly attending our webinar, Dr. Pankaj Gupta, Dr. Kameshwar Rao, Dr. Hiremat, and there are many people from other parts of country who are very regular. And this time, Saikat Sen Gupta, he was there from beginning, I think maybe now also. Thank you all for making, maybe because we keep good speakers and good topics, people are there and coming. Thank you very much. Now it is over to Binil. Before that, Udupa, you are there?
Yes, sir.
Praveen?
Very much. Yes, sir.
In this one, so when you are doing, please edit and put Dr. Sunil's in the our
Done, sir.
YouTube,
Done.
other one
Yeah.
YouTube. Second thing is, please prepare a certificate, because we have not done it so far. For all,
Yes,
we
sir.
have to send an e-certificate from the beginning till the end. We have to send certificate for all our faculties, both speakers and chairpersons. That is more important for the long term. Please prepare that, and you know who all are there. That also
Yes,
to be
yes,
done. And
yes,
you have to
yes.
send the e-certificate. So,
Yes, sir. Done.
thank you. Over to Binil. Anything for our president to say?
Oh, that's all
Rest-
right. It's really a wonderful experience with Ramesh sir and Dr. Sunil. Just a flow of talk with their experiences. Now I request Dr. Binil for a vote of thanks and concluding the meeting. Over to Binil, please.
Thank you, sir. First, I thank Dr. S. Ramesh, HOD of Kanchi Kamagodi Children's Hospital, Chennai, for sharing his experience with us. Sir, it was a wonderful show, and it was like watching a thriller movie. Thank you, sir. Thank you for being with us today evening.
I don't want to be any more thriller movies are enough.
I extend my
That's
sincere
good.
thanks to our own treasurer, ISI Kerala State Chapter, Professor of Sri Thirunaal Institute of Medical Sciences, Trivandrum, Dr. Sunil, for sharing his knowledge with us. He explained cyanotic heart diseases very nicely and clearly to us. Thank you, sir. I extend my sincere thanks to Dr. Balabhaskar, our academic coordinator and immediate past president, for moderating and chairing the session. Thank you, sir. Along with along with Chandrasekhar, sir. I thank Dr. Chandrasekhar CR, who is the HOD of Sagar Chandrama Hospital, Bangalore. And he is a pediatric anesthesiologist. I thank Chandrasekhar sir for being with us today evening. Thank you. And I extend my sincere thanks to Dr. Venkatagiri, our own man, our national president-elect, for organizing the entire show. I also extend my sincere thanks to Dr. Nasser, our state president, for helping me for organizing the webinar. Thank you. And I thank all the participants for joining us today evening. It was around 200 participants joined today evening, I think. Around 160 was in Zoom, and around 60 or 40 to 60
227 to be precise. 227.
227. Thank you very much.
That's wonderful. That is wonderful. And I recognize Rajiv Gupta.
I thank our GC members who national GC members, Dr. Rajiv Gupta joined us, and Dr. Kiran Gera joined us. Thank you, sir, for joining us. Also, our past president, Dr. Kameshwar Rao sir, and Dr. Chakra Rao sir was with us. So thank you, sir. And I thank Dr. Pankaj Gupta for joining us today.
Gupta, yes.
Yeah, always a pleasure. I feel Kerala is doing a wonderful job.
And anybody else I left, I don't know.
Sushil
And Kannan sir
Pokarna
also
is
was
there.
there.
Kannan is there. Sushil Pokarna is there. There are many. Yeah.
Thank you, sir.
Thank you.